we are going to be reviewing today. So we all know that sepsis is defined as a life-threatening acute organ dysfunction due to infection. And when this sepsis is severe enough to cause circulatory and metabolic dysfunction, resulting that it causes your patient to become hypotensive, requiring vasopressor support after the initial fluid resuscitation with lactates more than 2 millimoles is what constitutes the definition of septic shock, and of course it is associated with high risk of mortality. Now, in certain subset of patients, there is an uncertainty of defining or understanding whether it is actually sepsis or not. So, according to the Surviving Sepsis Campaign 2026, they've given the definitions, like the definition for definitive sepsis, which is confirmed based on history, clinical examination, and diagnostic testing, and an alternative diagnosis is very unlikely. Probable is high suspicion for sepsis. Again, the diagnosis is based on the history, clinical examination, and diagnostic testing. And alternative diagnosis is less likely in the probable. So definitive and probable sepsis is the sepsis confirmed. Then possible sepsis is moderate suspicion for sepsis, and a sepsis is a possible diagnosis. However, an alternative diagnosis is also likely based on the history, again the clinical examination and diagnostic testing. An unlikely sepsis is defined as low suspicion. Clinical assessment is not consistent with sepsis, and an alternative diagnosis is more likely. So these are the sepsis definitions which have been given this year according to the Surviving Sepsis campaign. Then, how do you define this organ dysfunction? What do you assess on the bedside? What would you look in your patient? A patient who has a new oxygen requirement is becoming hypoxemic. There is worsening of his respiratory status. He's tachypnic, develops a new infiltrate on the chest X-ray. His secretions have become more purulent. Has become hypotensive, has tachycardia, is requiring vasopressor support now, has a new onset confusion, was drowsy, agitated, or maybe even delirious. Oliguria is one of the early signs to identify hypoperfusion. Then, of course, you can look at the creatinine trends of the patient. The patient may have high or rising lactates, may be acidotic, may have deranged sugars. Then there are certain subset of patients, which you keep a very, you want to assess them quicker, like patients who are neutropenic, those who are post-transplant, patients on long-standing steroids, elderly, CKD patients, and those with long-standing devices. So these are your particular high-risk hosts who, you need to have keep a low threshold. You are able to take medicines? So now there are certain screening tools which have been recommended to be used not only while your patient is being shifted, for example, he's coming in the ambulance, you're assessing, you use these bedside screening tools to assess the severity, inform your hospital in advance so that they are prepared, so that there is no delay in taking the samples, initiating the antimicrobial therapy as soon as the patient arrives. But these can also be used bedside in the ICU when the patient gets sick. So the new recommended scores that are recommended as per the 2026 guideline are the news to the scores, the MEWS or the SIRS. Why they are better than QSOFA is because QSOFA is specific for bad outcomes, but it is insensitive for early screening. That it will be there. And a positive QSOFA score is a deterioration signal. So these screening tools should be used as early, and they should be used on the bedside for quick assessment and early response. Now, code sepsis is another recommendation that there should be a code for sepsis, like you have code for other problems, like we have code blues in the hospital. So now code sepsis is essentially to have parallel execution of everything, not to have a long discussion. So this team should include about 4 to 5 people, wherein there's a leader who identifies the probability, the presence of sepsis, starts the initial management as soon as the patient As soon as he identifies, then you have a nursing staff who's taking care of the vitals, gaining access, sending the appropriate samples, a physician intensivist who's taking care of course, the airway breathing circulation, but identifying the source and initiating appropriate management, while simultaneously sending the micro samples to the microbiology, and you have a microbiologist in place who takes care of the sample processing and giving you the culture results, and of course the pharmacy. So it's a team of about 4 to 5 people, and this helps in fast and parallel execution. Now, the importance of the first hour. So, when your patient arrives to the hospital or you identify a patient who's been in the hospital and develops sepsis, you need to be able to recognize within the first 1 hour. You need to be able to understand the parameters that I just talked about, organ dysfunction. The first initial step is to always stabilize the patient, gain IV access, send the samples, whether it's your microbiological samples, lactates, blood gas, everything together. Then start timed empirical antibiotic antimicrobial therapy. This should not be delayed in order to send the samples. Then, of course, achieving source control simultaneously. If there is an abscess, you need to start preparing for draining that abscess. If there is a line that needs to be removed, so accordingly, the first are involves recognizing, stabilizing, sending the samples, starting the empirical treatment, and achieving source control. Now, patients with probable and definitive sepsis and those with sepsis with hypotension or organ hypoperfusion are the ones who require antibiotics to be given within the first hour. High risk immunocompromised hosts, those with severe pneumonia, neutropenic patients, they also require initiating antibiotics within the first 1 hour. The 3R evaluation is for possible sepsis without shock, patients with stable vitals, and no rapidly progressive organ dysfunction. So, the first 15 minutes of arrival would include you securing your airway, assessing the patient's mentation. Does he require intubation? Does he require airway protection? Looking at the saturation levels, looking at the respiratory rate. Does the patient require oxygen? Does he require NIV? Sending the blood gas simultaneously, assessing the circulation, looking at the mean arterial pressures, quick capillary refill time, bedside. And of course, this is going to require an IV access immediately. And then, of course, like I said, sending the lactates, measuring urine output because oliguria is an tells you about the early perfusion and organ dysfunction, and escalating timely if there is any worsening, whether it's oxygen, mentation, or perfusion. So do not separate the infection workup from resuscitation. Everything has to run together. Then, very briefly about the pathophysiology of septic shock. You have a patient who's got infected with a certain pathogen. There is going to be a host response, which is going to lead to an inflammatory cascade, resulting in endothelial injury and vasodilation, which would result in capillary leak, dynamic fluid shifts, resulting in hypovolemia. Patient would have a low SVR, may or may not have a septic cardiomyopathy. And of course, there's going to be rising lactates, organ dysfunction, which would suggest tissue hypoxia. So, shock is not only low pressure, it is failure of effective tissue perfusion. Now, when you're resuscitating your patients, there is a specific hemodynamic phenotype. Now, remember, one specific phenotype may be predominant in one, and similarly. So, a patient may be particularly fluid responsive. So, small boluses would give you the response. It would give you an improved stroke volume after the passive leg raising. There may be a vasodilatory phenotype. So, patient would have a low diastolic pressure and wide pulse pressure, would require norepinephrine early. A patient would have a cardiac dysfunction as the predominant phenotype. So, may have poor LV-RV function, pulmonary edema. So, the vasoactive plan should be guided by bedside echo in such patients. The initial fluid resuscitation. When you have a patient who's presented in sepsis and septic shock, use of balanced crystalloids for hyperperfusion is what is the recommended fluid of choice. And as per the Surviving Sepsis Campaign 2026 also, they suggest at least 30 ml per kg within the first 3 hours for sepsis-induced hyperperfusion or shock. They should be given in aliquots with frequent assessment, and dynamic variables should be used for reassessment. Something important to remember, do not blindly load your patients with fluid, especially the ones who are elderly, those who have chronic kidney disease, heart failure, RV dysfunction. Don't chase urine output with repeated boluses and ignore patients developing pulmonary edema. Don't ignore the rising lactates, increasing work of breathing of your patient. And of course, while you're doing everything, you must remember it is important to achieve source control, start source control simultaneously. So, like I said, you assess the fluid resuscitation with dynamic parameters rather than static parameters. So dynamic parameters can be your passive leg raising, mini fluid response, pulse pressure variation. You can use an echo, bedside focus to look at the IVC, signs of pulmonary edema, and then you need to know when do you need to stop. If there is no response, if your lungs are getting congested, and what is fluid responsiveness? It is when you give a fluid bolus and there is an increase in cardiac output of 10%. That is what is defined as fluid responsiveness. So a fluid bolus should have a measurable response and a stop signal always. You should know when to stop. That is also equally important. Now, this has come into practice with landmark trials. There have been uh, there have been landmark trials in the fluid strategy, starting with the Process, Arise and Promise trial, which said that protocolized early goal-directed therapy did not outperform good usual care when early recognition and antibiotics improved, which is contrary to the reverse trial, which said that protocolized ETDT actually did outperform. That is probably also because the good usual care has dramatically improved over time. Then the classic trial, which compared the restrictive fluid strategy after initial resuscitation, which did not worsen outcomes and supports avoiding fluid access. Clover's trial, which compared restrictive versus liberal early resuscitation, and it showed no overall mortality difference. So it said that it has to be individualized. The SMART trial, which said balanced crystalloids reduce kidney-related adverse outcomes in some critically ill populations. Then the Surviving Sepsis Campaign 2026 again enforces that use initial resuscitation and reassessment and fluid responsiveness rather than blind ongoing fluids. So you need to start fluids promptly when the patient is hypoperfused. Stop when it no longer gives you a response and your patient starts to show signs of fluid overload. So another important aspect, markers of hypoperfusion are your lactate and capillary refill time. So lactates are markers of stress physiology and hypoperfusion risk. They are measured early and they should be repeated if they are elevated initially. Rising or persistent lactate always needs a review, and they are not always infection specific. Now, capillary refill time is a fast bedside marker and it's useful for reassessment. You must remember when you're using this to look for mottling, cold extremities, as well as the poor mentation of the patient. This capillary refill time came more into practice after the Andromeda shock and the Andromeda shock 2 trial, which compared the capillary refill target resuscitation with lactate target resuscitation in early septic shock. So peripheral perfusion is a fast and repeatable bedside marker, and it encourages resuscitation guided by a clinical perfusion and not just blindly relying on lactate levels alone. Another advantage is that you can check the capillary refill repeatedly and always use lactates as trend along with the clinical context. Now, after your initial fluid resuscitation in patients with septic shock, the next step, if the patient is still not able to maintain the mean arterial pressures, you add vasopressors because of persistent hypotension and hypoperfusion. So the first line drug of choice, the vasopressor of choice is norepinephrine to maintain a mean arterial pressure of 65. Of course, this has to be individualized in elderly, fragile patients, and even those with chronic hypertension. The gold standard route of choice is central access, but in the initial phase, while you are achieving your central access, you can start with the peripheral line, just as a temporary measure. And of course, you need to reassess, check the lactates, perfusion, urine output, and always monitor for adverse effects. And you escalate to vasopressin or epinephrine or an inotrope, especially in patients with low cardiac output like dobutamine, based on the phenotype and of course the dose requirement to maintain a mean arterial target of 65 millimeters of mercury. So just to summarize, the vasopressor sequences, norepinephrine is the first line to restore the mean arterial pressure. Vasopressin, add, you add in when the norepinephrine dose is rising. Epinephrine is an additional agent, dobutamine and low cardiac output, despite the mean arterial pressure, and hydrocortisone when there is a persistent vasopressor need. So you add the drugs according to physiology and not just because the blood pressure is low. So in most adults, the mean arterial pressure target is 65. For chronic hypertension, you may need higher targets. For elderly and failed patients, avoid excessive vasoconstriction. You titrate to clinical perfusion and always watch for adverse effects. And you watch for adverse effects in all patients. And patients with septic cardiomyopathy or RV dysfunction, mean arterial pressure is alone not sufficient. So you always do it echo guided, monitor your lactate levels, and you assess for the perfusion response. Like I said, corticosteroids are recommended in patients with ongoing septic shock requiring persistent vasopressors. IV hydrocortisone is the drug of choice, given in doses of 50 milligrams IV 6 hourly, and the goal is for faster shock reversal. A little bit about oxygen, respiratory failure, and ventilatory support. Patients with pneumonia, ARDS, those with pulmonary edema often require oxygen and respiratory support. So you should start oxygen early. These days it is preferred if the patient is hypoxemic to start with HFNC. If the patient has hypercarbic respiratory failure, increased workout breathing, you can initiate NIV. You should assess for intubation simultaneously, look at the patient's mentation. If there is a risk for the airway compromise and you need to protect the airway, so you need to do the intubation early. Now, when you have a patient of sepsis and you are initiating resuscitation, stabilizing your patient, you need to send the microbiology samples as well. So you send cultures, you send blood culture in every patient, 2 sets from 2 different sites drawn simultaneously. You must send at least 10 ml of sample in each of the bottles. And depending upon the presentation and the clinical syndrome, if it's a respiratory infection, you send in your patient's secretions, whether it's endotracheal, TT secretions, or BAL. If you're suspecting urosepsis, you send the urine samples. Remember, if a patient has a long-standing Foley's catheter in C2, remove, change the catheter, and then send the fresh urine sample. If the patient has a pus collection or has CNS involvement, you accordingly send the sample from the involved site. For line-induced or catheter-related infections, remember that you send the sample from the suspected line, from 2 lumens and peripheral simultaneously, and then you document the site as well as the differential time to positivity. Source localization. While you are doing all this, remember that initial assessment and management of your patient begins with history and always head to toe examination. So you must examine your patient head to toe. Right from the head, you look at the oral cavity, which is very important. Look at the sinuses. You may have necklines in situ, which may have erythema and induration. So you must examine. Look at the chest, the heart. If you auscultate the heart, you might hear a murmur, which could, give you clinical clues that that patient could have infective endocarditis. Examine the abdomen of the patient. Look at the skin. Look at the limbs. There might be an isolated unilateral limb swelling, which could be suggesting DVT. So, unless you examine your patient, you remove the dressings, you examine the lines, you must also examine the drain sites and the pressure areas. The pressure areas and pressure injuries are equally important and they must be checked. especially when you're looking for the source of infection. Then source control, you need to remember if there is an abscess, if there's an empyema, if there's an infected collection. To achieve source control, you need to drain it. Remove that infected catheter, that non-essential device, or that infected prosthetic material. If you need to debride the diabetic foot, you do that. You plan that. You may have to operate a patient for the ischemic bowel or perforation or a leak. Unless you do that, you will not achieve source control. And of course, you can use ultrasound and your CT scans to understand whether you've actually achieved source control and if you need to further intervene. And reassess. If your patient has persistent shock or fever, after you've achieved initial source control, it could mean that you are missing or there is something that is still lagging, which you need to reassess to achieve the adequate source control. So, when you initiate antimicrobial therapy, antibiotics, you need to know which patient to initiate. Probable and definitive sepsis or a deteriorating host. Avoid reflex in low probability mimics. Just don't give antibiotic because you can start an antibiotic. Right source. If you're choosing a drug, remember that drug should penetrate the site. For example, in a lung infection, if you're giving daptomycin, it will not be effective. So you need to know what drug you're choosing. Always keep in mind the possibility of MDR risk factors and accordingly choose the antibiotic. Dose. Loading dose should not be adjusted based on the renal function. You have to give full loading dose. Maintenance doses are modified based on the renal phenotype and if the patient is obese. Timing. First 1 hour you need to review at 24 to 48 hours. When you get your culture reports, you've achieved source control, and you need to decide the duration of treatment for your patients. How would your empiric antibiotic regimen look like? So, if you have a patient with pneumonia, whether it is CAP, HAP, or VAP, it would depend upon the presentation. Then the choice of antibiotic would depend upon the local antibiogram. In case of urinary infection, you need to cover gram negatives. ESBL and CRE cover only if there is a prior history of isolation, if patient has just recently undergone instrumentation. In abdominal sepsis, sorry. Uh, for abdomen, you cover with gram negative cover.
Please switch off. Just connect from one side.
For gram negative and anaerobes, skin and soft tissue, you need to cover for streptococcus and staphylococcus. And in case of Lyme, always cover for gram positives like staphylococcus, but gram negative and you may have to give antifungals if your patient is unstable, is neutropenic, has a femoral line, or maybe has been on TPM. Then the beta-lactam infusion strategy, which is come into practice. Always give full loading dose. As I've just discussed, never modify it based on the patient's renal function. Maintenance dose can be extended or continuous infusion. Your target is to maximize the concentration of the drug over MIC at all times. In patients with severe infections, septic shock, you want it to be 4 times, 100% of the time above MIC. You adjust the dose based on the renal phenotypes and obesity, and you review based on your culture sensitivity reports, therapeutic drug monitoring when it's available, and of course, you check for the adverse effects. So, this beta-lactam strategy came into practice more after the Blink 3 and 2024 meta-analysis, which said that the prolonged infusion of beta-lactams was associated with lower short-term mortality. So that is why full loading dose followed by extended or prolonged infusions is what is the recommended strategy for all beta-lactam drugs. Now, a little bit about therapeutic drug monitoring. So, therapeutic drug monitoring, when you are using, it should actually result in a change, whether you modify your dose, you increase, decrease, or you even stop the drug. It was initially recommended only for vancomycin, but now they also recommend it for aminoglycosides, beta-lactams, as well as azoles and linezolid. Briefly about biomarkers. Now, biomarkers are adjuncts, they are not decision makers. They are good for supporting discontinuation when your clinical course aligns. Remember, a low PCT should not withhold antibiotics in high probability sepsis. And similarly, a high CRP or a procalcitonin does not prove bacterial infection because there are conditions like post operative trauma or even uh, conditions wherein there is increased inflammation in the body which can cause false positives. So, always look at the trend, use them for de escalation and not for initiation of your antimicrobial therapy. And don't ever rely on a single value of these biomarkers. What do you monitor? You monitor the patient's mean arterial pressure, the requirement of vasopressor dose, whether it's increasing, decreasing, the capillary refill time, the mentation of the patient, lactate trends, blood gas, urine output, the creatinine trend. You look at the oxygen saturation, the PaO2 levels, and also the source of the infection. When you get your culture results and whether you've achieved the source control or not, and whether your antibiotics that you've given, whether their doses are adequate or not, and whether you're getting the desired response from your patient or not. Then, briefly about septic cardiomyopathy, a certain subset of patients do develop septic cardiomyopathy, which is persistent shock despite the mean arterial support. Patients may have LVRV dysfunction and low stroke volume and high vasopressor dose with poor perfusion. So you should consider inotrope if patient like dobutamine if patient has low cardiac output despite adequate mean arterial pressures. Sepsis-induced AKI is another entity. Patient may have rising creatinine and oliguria. You want to restore the perfusion and avoid fluid overload. The dose, initial dose, we do not modify. We only adjust the maintenance doses. Always remember about toxicity. Monitor for it, and do not, if you can, avoid other nephrotoxic drugs. CRRT dose depends upon the effluent rate, downtime, and residual urine. And always reassess your patient daily because yesterday's AKI could be an underdosing today. If your patient is recovering, you need to modify that dose the next day. Then, briefly about adjuncts. These therapies have practically no role, like vitamin C, metabolic cocktails, antipyretics only used for comfort, probiotics because they increase infection risk in vulnerable populations, blood purification is not a standard in early sepsis, and SDD is only used in low resistance settings. So, the 24-hour review should be clinically, you should be able to reassess how's your patient, how are the symptoms, how is the organ dysfunction, whether there's a response or not, what is your microbiology showing. Imaging may help you to understand the source control response and whether you de escalate or escalate at this point of time and decide about the duration and review daily to understand the response of treatment. There are a certain subset of population, patient population, who may have who may remain culture negative. So you need to reassess the diagnosis. Is it really a true infection or is it a mimic? Did you give did you send the samples after the patient had received antibiotics? Did you not send appropriate sample? In cases of blood culture, did you not send even 10 ml properly? Then you review with imaging if needed. Have you missed a deep source of infection? Look at the trajectory. Is the patient really improving? If he is, then it's okay if even if the culture is negative. Or is he worsening? And then decide about your antimicrobial therapy. So mimics like pulmonary embolism, edema, pancreatitis, decay, there could be vasculitis, and even tropical fevers. So you need to keep this in mind. Unless you remember them, you will not be able to rule out. So what you should not do, you should not delay the antimicrobial therapy, waiting for reports. And also, you should not delay therapy in a patient who's deteriorating. Do not overtreat. Start broad spectrum antibiotics or keep changing your antibiotics without any proper source. Do not culture, do not send superficial swabs, send samples from old drains because these are all colonizers. And do not keep giving your patients fluids without reassessing and without knowing when to stop. Do not ignore do not forget about source control because just antimicrobial therapy and sending cultures is not enough. You always have to achieve source control. And don't use this practice of just in case there's an infection. Don't do that, especially when you know that there is a very high likely possibility that this is not infection. So to summarize the take-home messages, classify the probability, know what is possible, probable, and definitive sepsis. You need to understand that shock is perfusion failure. Do not only treat the mean arterial pressure. Follow lactate trends. Look at capillary refill time. Look at the urine output and mentation of the patient. Adequate first antimicrobial exposure matters a lot. Source control is equally important to achieve the desired outcome, and you must review your patients daily. So you must recognize infection and organ dysfunction, achieve early stabilization, send the samples, but do not delay therapy in order to send the samples, start timely empirical therapy in optimized dose, achieve source control, and reassess your patient daily because early sepsis care is a disciplined urgency. Thank you.
ठीक है, मैं पता करता हूँ
Thank you, Dr. Aakanksha,
कल पता
for
करके
giving
मैं
a
आपको
recap
बताता
of the last module. So now we go on to the modules for today, and that is on hospital-acquired pneumonia and ventilator-associated pneumonia. So I have great pleasure in introducing Dr. Despoina Koulenti, who has given us time and has joined us all the way from UK. She is currently
tomorrow is going to first standard. This
just a second.
So he needs one certificate with this.
Sir, you have to bring his vaccination schedule card, original. And second, if they are giving any
She is
format,
currently
you have to bring
consultant
that
critical
format.
care in College Hospital, London,
No
UK.
format, you
Your
have to.
letter.
She
That
is
I'll write
visiting
and give. You
professor,
have to bring
Faculty
it
of
his
Medicine,
original
University of
vaccination
Vassili,
schedule
Greece,
card.
and School of Health Sciences, University of Bologna, Greece. International renowned intensivist researcher and educator
Original
with an
and
extensive experience in
because
critical care medicine
last
and
4
infectious
days,
disease.
so many people they had cheated.
And she's
And I got
done
to know
wide
that.
publications,
Okay.
and
So now I'm not
she
seeing the
works for
photos.
the UK Center for
looking the
Clinical
original.
Research, the University
And
of
after
Queensland,
cheating today, they
Australia.
came.
She's
They are
done
saying,
there.
sir, no, it is by
And her great
mistake, this,
interest in
that, and
medical
all
care
that.
medicine,
So
intensive
I
care,
got
hospital-acquired infection, sepsis, antimicrobial
What time will be
resistance,
there,
and clinical
till 9
research.
o'clock I'll be
Over to
here.
you, ma'am, to
Come
conduct
again.
the today's proceeding.
Thank you very much for the invitation. It's an honor to be here with my Indian colleagues. I would like to disclose also that I'm the current chair of the European Society of Clinical Microbiology and Infectious Diseases group of critically ill patients, and also the vice chair of the Clinical Liaison Council of ECRED, the European Clinical Research Alliance on Infectious Diseases, and member of the executive committee of the study group of infection in the ICU and sepsis for VISAC. I have the pleasure to introduce our first speaker, Dr. Senthur Nambi, that is infectious diseases specialist in Apollo Hospital, Chennai. Dr. Senthur Nambi, the floor is yours.
Good evening, and thank you, Dr. Rajesh Chawla. Thank you, the chairperson. And let me share my slides.
I'm not one. You had any
I
medicine?
think just speak louder.
Close it now. I'm trying to also
ನನಗೆ ಆಲ್ರೆಡಿ ಒಬ್ಬರಿಬ್ಬರು ಪ್ರಿವೆನ್ಷನ್
Are my slides visible?
Yes, they are.
Yeah. Thank you. Good evening. The topic allotted to me is the diagnosis of hospital-acquired pneumonia, ventilator-associated pneumonia, and early reassessment. And the question is, how does this healthcare? And if you see healthcare as an industry, you could see that healthcare comes as one of the most hazardous industry when you compare with even bungee jumping, ski driving, or whatever it is, healthcare is industry standpoint is actually considered hazardous. Even probably if your residence is near a nuclear power reactor, then also it is much more safer. It comes under the HR
Take rest,
safety.
drink
So that
more
is where
water.
the healthcare stands, and this is a cockpit of a commercial passenger aircraft, and this looks confusing and this looks very challenging. And this is a post-cardiac surgery patient, and
Any
taking
medicine
the
allergy you
cockpit
have,
is
ma?
problematic to
medicines you are
handle, and
taking?
so is
Nothing,
these
just an
lines
oral
and
capsule.
tubes out of a cardiac
Medicine.
surgery patient too. So we need to understand that
And also
from
thyroid.
that perspective when we view healthcare as a hazardous industry. But the fundamental question is, why is healthcare dangerous? Because no one goes for a bungee jumping or skydiving when their health is at stake. The problem with healthcare as an industry is people come for medical issues. Once they come for medical issues, they're already compromised. Starting from skin, mucosa, you got those lines and tubes, antibiotics. So that makes them at a risk for picking up a new set of problems. So that is why healthcare is dangerous. When you see it from an industry standpoint, it becomes a little minuscule view of the entire problem. Personally,
morning,
I
afternoon,
am not
night.
a big fan of this
Support CB200
term
morning, night. Both are
hospital-acquired
after food.
infection.
And to say DSR morning,
In
night
my
before
opinion,
food.
I don't think this
Last
terminology
morning,
is
night
correct. I would always
after.
call
Bring
it
this
as some
injection.
new onset infection after hospitalization. When you put this term hospital acquired, the primary blame shifts to the
I was
care
taking class,
provider.
that's why not
And in
able
an
to take
Indian
the.
society,
So
when
I
you
asked
have to
this brother to give one
these
spoon.
kind of problems,
Okay. I
this was
transfer my
mindset that
WhatsApp
what
over
we
there.
used to but
Because
probably
every
in the
Tuesday
time where
it
we
will
have
be
to
there
reassess,
online.
Okay, you
renaming
will be taking or you are taking?
No, I am
hospital-acquired
taking class.
Okay.
This
infection.
for
All we
fellowship
can do
from
from a
UK.
hospital is
Okay.
have
So
systems
that is
in
the reason.
place.
The people
If you are
won't
expanding a
leave it.
hospital,
An exam
have
will be
zero
there after
infections.
that.
I don't think that's
no worries.
practically
What
possible.
happened to you?
All we can have
ಕೋವಿಡ್
is
ಅಂದ್ರೆ
zero
ಮಧ್ಯಾಹ್ನ ಮತ್ತೆ
tolerance
ಸಂಜೆ
to
ಫೀವರ್ ಇತ್ತು.
infection.
ಈಗ ಸದ್ಯಕ್ಕೆ ಫೀವರ್ ಇಲ್ಲ ಅಂತ
So
ಅನಿಸ್ತಿದೆ, ಬಟ್
you will need to have a
ಮಧ್ಯಾಹ್ನ ಸ್ವಲ್ಪ ಸಂಜೆ
balance
ಜಾಸ್ತಿನೇ ಇತ್ತು
where
ಫೀವರ್,
you don't
ಸುಸ್ತು
shift the
ಅನಿಸ್ತಾ
entire
ಇತ್ತು.
blame on the
ಸೊ
hospital.
ಮೈಕೆ ನೋವು.
It is at different planes. You need to understand that at best the hospital can always aim for zero tolerance to infections, but not zero infections. Some hospital is reporting zero infections, then you need to think twice
ಮಧ್ಯಾಹ್ನ ಸ್ವಲ್ಪ
before
ಜಾಸ್ತಿ
looking
ಇತ್ತು.
into the data or trusting that data. Going on to hospital-acquired infections, because it's still that the terminology, so I would use that terminology, hospital-acquired
ನಿನ್ನೆ ಸ್ವಲ್ಪ
infections.
ರನ್ನಿಂಗ್ ನೋವು
It all depends upon the type of infection. It always depends upon the unit or the type of hospital that is in. In common is actually a urinary tract infection, and then number 2 would be a surgical site infection. Then you have a bloodstream infection. Then you have those pneumonias. But if you're going to take an ICU per se, then probably your bloodstream infections and pneumonias are the number 1, number 2 as healthcare associated or hospital-acquired infections. The problem with hospital-acquired infections in a country like India is we still do not have a national surveillance system in place. In general, most of the ICUs don't have any precaution of practice. There is wide variability in the care, so it's very difficult to compare between ICUs.
No cold, no citrus,
We
no
all
junk.
know that
And little
VAP
warm water
is
to
an
drink.
important component of hospital-acquired pneumonias, and in an ICU, VAP is the second most nosocomial infections after the bloodstream infections. There is some data, especially with the INEC group, there is some data from Southeast Asia, South Asia, Latin America. When you compare with what is published or what is available in public domain with the NHSN criteria, what we understand is the infection risks or the device-associated infections is actually 3 to 5 times more when compared to the NHSN data. And we all know that any hospital-acquired infection results in prolonged length of stay, and of course it can kill. There could be a crude mortality rate, at times it could be an attributable mortality rate also. And the problem in a country like India is it's not insurance. 80% of our patients actually pay out of their pockets. So when there is an event,
So
happening,
Madam
after getting hospitalized for some other problem, it really adds on to the cost. Leave alone the medicine cost, number of days that are added, the number of procedures being added.
Office meeting ಇದೆ
Burn
those
a
continuous ಆಗಿದ್ದಾರೆ
financially, the average Indian patient
ಸ್ವಲ್ಪ ಆವಿ ತಗೊಳ್ಳಿ
pays
ಜಾಸ್ತಿ
out
ಭಾರಿ
of their
ಜಾಸ್ತಿ
own
ಇದೆ
pocket. So
ಇಲ್ಲ
we need to
ಇವತ್ತಿನ
always
is
have a
fine but
mechanism
yesterday ಆಫೀಸರ್ ಇತ್ತಲ್ಲ
by which
so
we can
just
prevent.
AC
But
it
to
will
have
be
the
little
mechanism,
great.
we need data, we need measurements. That is when you have accreditation systems in place, like the JCI or the NABH, there is some system in place so that you have some data by which hospitals can be compared. INEC is one set of organization, which is the International Nosocomial Infection Control Consortium, where you have data which is pertaining to the so-called less privileged nations all over the world. Because in the UK and US, Canada, Australia, the systems are fairly well established, whereas other countries kind of lag behind in terms of quality systems and infection control programs. Going on to the topic per se, the burden of the hospital-acquired pneumonia, what we call as the non-ventilator hospital-acquired pneumonia, it's quite common. In one study, it was almost up to 60 to 70% of all the hospital-acquired pneumonias. Why is this component important? Someone has picked up a pneumonia in the hospital, maybe he's there in the ward or high dependency unit. A few of them, or even 1 out of 2, will require an ICU care. 1 in 5 will need a mechanical ventilation. The length of stay goes high, and at times you can have a 30% mortality rate. This is something unique to a set of population who will depend upon care being given by others. This is typically seen in the elderly population, the geriatric population, someone with an underlying neurological problem, someone who's got aspiration issues, someone who has sensorium who's on the lower side. These are the subset of patients where we have to pay more attention to prevent hospital-acquired. We need to look into the oral care, look into the patient mobility, maybe have the patient in head and elevated, reduce the use of proton pump inhibitors, minimize sedation, look into dysphagia screening, look into natural feeding, follow standardized process to place the feeding tubes, breathing exercises, chest physiotherapy, incentive spirometry. So these are not something that I am mentioning for a ventilated patient. These are all the vulnerable population who cannot take care of themselves on their own, but still they would need these kind of monitoring measures while being in the ward so that we can prevent microaspiration, aspiration, and the development of hospital-acquired pneumonia. And these are not just simple measures. This is one Canadian hospital where they looked into these measures, pre-measures, look into the hospital-acquired pneumonia rates, and then post-intervention, what was the pneumonia rates. They did find by paying attention to these factors, they could reduce the hospital-acquired pneumonia by almost 30%. And that's a good number. When you're looking at no high-tech measures, just paying a little more attention to those subset of patients who are at risk of developing an in-hospital pneumonia. This is an influenza season in India, and this is COVID season also in India. We all know that most of the respiratory viruses, not only with respect to influenza and COVID, generally they result in disruption of the respiratory tract mucosa. Someone could have come to the hospital with an influenza, but by day 4, day 5, they may develop a secondary bacterial infection. That's typically because of a pneumococcus, Haemophilus staph aureus. In technically speaking, this would be called as a hospital-acquired pneumonia because this is something that happened 48 hours after the hospitalization. But we may have to count into the fact that this patient did have a viral respiratory infection. So we need to look into all these factors, especially whenever we are going through an influenza
In this so many
or any
vaccines
other
it is not done,
seasonal
sir.
virus pandemic.
This is
Even
government
before we
whatever they
make a
prescribed.
diagnosis of
That one
bacterial
only vaccine.
pneumonia,
No,
we
this
need
is
to be
with
aware of
Karnataka
the
government. It
pneumonia
is
Yeah,
not
mimics.
a standard one
Be
also.
fluid in the lungs, pulmonary edema,
See,
collapse, atelectasis,
they are giving
pulmonary
only MR.
embolism.
This
Someone
is
who
MR.
had
It is
a
not a
transfusion
standard
of
one.
blood products, transfusion
Standard
associated
one it will
lung
comes
injury,
MMR.
pulmonary hemorrhage,
Measles, mumps
mass
and
lesions,
rubella. They are
which
giving
look like
only
pneumonia.
measles and
And
rubella.
even if there is a
Mumps they
pneumonia,
are not
we need
giving.
to look into non-bacterial
Here
etiologies for pneumonia.
and here
It could be microbacterial, it could be viral infection,
this
it could be fungal, or at
in
times it could
Easy
be
6
pulmonary
they have to give.
vasculitis.
They are giving
So
Easy
before
5,
even
sir.
we label as a hospital-acquired pneumonia,
See,
So
my
I think we need to think
pediatrician
twice
also
before
checking, sir.
giving that label. We need to
I
be
don't have
aware of
any
these
issue, sir. I'll write only
bacterial
as per the
pneumonia
Karnataka
mimics.
government.
Yeah, because
That
this
will
is the only
depend
we will
on,
get it now. But how
Patient
we can
twice.
check it that this is
If we are
not
going to
done,
develop
or
a
how do we
this
know as a
patient
parents,
has
right? So we will follow this one because my wife is from village.
most of us would send
So
an
she was there when he becomes first year, na? Till first year she has done all the vaccine there only. So we continued at least for the whenever that vaccination is there, we will get a call. So whenever we are going
no,
on the
there are
weekends,
so many vaccines it won't be there,
send a
sir.
respiratory
Because
secretion
even
for
I also cross-checked
clinicians
here
need
in
to think, is my clinical
Dolgopi.
diagnosis pneumonia?
There
If
also
my
so many
clinical
vaccines it
diagnosis
is
is not pneumonia,
pendings and
then I
missing.
should think
So many
twice
people.
before sending the
They
respiratory
won't give
samples
proper
for cultures. Because we all
vaccinations.
know that someone on the ventilator with the endotracheal tube
And
on
nothing
by day
special
4, day
vaccines
5,
also they
there will be
will
always
give.
some colonization there.
means
So it is very
All like
important
Japanese
to have the clinical
encephalitis,
diagnosis in before
pneumococci
sending
and all.
samples for culture.
those are for what, sir?
Terrain
What
is
were
everything.
those
The
are
germ
for
is
flu
nothing. We need to
Last
always
flu.
give the pneumonia,
Flu they
not
won't
the
give.
endotracheal
Flu
culture
you
group.
leave it.
So think
Basic
twice before
mandatory
sending
vaccines
cultures.
also they won't give. They will
What
cut it
is
and give.
ventilator-associated pneumonia?
means it's not
It is
written
defined
here.
as
You are saying
pneumonia which occurs more than
whatever
48
In that
hours
schedule only it is
after
not there,
patients
sir.
have been intubated
Done.
and received mechanical ventilation. So day 1, day 2, you would always wait before blaming the so-called ventilator. Kindly remember, the ventilator rarely does not give the pneumonia. The ventilator has been placed because the patient is not able to take care of himself. If we keep that in mind, let's not blame the ventilator for the pneumonia. We need to keep that in mind before we ascribe the term VAP. So
If
from
suppose
that,
you are
these
sending
patients
for out of country,
pick up those organisms.
this
It
is
comes from the
not
patient's own
you can't.
flora. It could be from their sinonasal flora, oropharyngeal
here.
flora, what is there in the tracheal, what is there in the NAS, and then what is there in the gastric secretions, and then you're going to give PPI. Definitely the gastric hydrochloric acid is low, so there will be bacterial overgrowth in the stomach.
Full
What
name,
is
sir?
there in the aerodigestive tract
Practising.
actually derives pneumonia in hospital. It can be exogenous too. It can come from
Age?
healthcare workers. It can
6
come from the nebulizers that we use because
September
of these
bomb, sir.
tubes,
So
biofilm formation is there.
6.8.
There could be ventilator circuits that could get colonized. But we need to understand that in almost 80% of the patients, it comes from one patient's own flora. The key component being aspiration, microaspiration. We need to keep that in mind whenever we think of ventilator-associated pneumonia. There are two components. One is known as the early VAP, the other one is the late VAP. Pneumonia in a ventilated patient, which happens within 5 days, you're looking at early VAP. In general, you expect the normal oropharyngeal flora. It could be Staph aureus, pneumococcus, Haemophilus. In general, in that, you don't expect the multi-drug resistant gram negatives as a cause. Then you have the late VAP, where you have, in India, you're looking at resistant gram negatives. We rarely have MRSA or MRSA as a cause for VAP in our country. It's typically Acinetobacter, the Pseudomonas, the carbapenem resistant Klebsiella, at times you'll have E. coli. In general, with early VAP, we expect sensitive pathogens, whereas with late VAP, anything more than day 5, you're looking at resistant gram negatives. It's very important to understand that we cannot get our antibiotic choices right unless we have our own local data. You need to have your local antibiogram. Unless we have the antibiogram which is pertaining to the unit, the local epidemiology, without which getting an empiric antibiotic is very difficult. Practicing in India, especially with respect to antibiotics, unfortunately we cannot follow what is being done in the UK, Europe, or the US. There are risk factors for multi-drug resistant pathogens causing VAP. Someone who's received antibiotics more than, especially in the last 3 months. The current hospitalization, if it is more than 5 days. Someone who's been hospitalized more than 2 days in the preceding 3 months. Someone who's getting IV antibiotics at home, dialysis, home wound care. Someone in the family with an MDRO is a patient on immunosuppressive therapy. So these are all the multiple risk factors. The patient may have more than one, and they have it empirically. They do not have the epidemiology. You practice in a small center, go by these risk factors before you try to cover resistant gram negatives. This is a 63-year-old male with hypertensive CVA who's come to the ER.
नमस्ते अंकल, क्या समाचार है?
समाचार ठीक है, हमको कुछ प्रॉब्लम नहीं है, लेकिन बीपी का कंडीशन है उसको आप देखिए और एक प्रॉक्सी पे लिखिए, हम डेली शाम को आ जाया करेंगे, दवाई कब तक आ जाएगी?
There is no change in the FiO2 or the PEEP requirement. He does have a central line and a urinary catheter. So,
अभी 1-2 दिन तो ऊपर नीचे आ सकता है, उसके बाद
अब आज से नमक खाना बंद करता हूँ।
थोड़ा खाना है नहीं,
थोड़ा खाना है।
This is a common scenario in our ICUs. Remember, this patient does have an endotracheal tube, but does have a central line too, urinary catheter too. So we have to be very careful before we think
150 by 80
that the ventilator has to be
दवा खाना है, दवा आपको खा रही है।
issues in ICU, we think that can limit the VAP. Chest X-ray, even though as
डेली शाम को मैं आता
rely upon it,
रहूँगा, एक हफ्ता कहीं जाएंगे नहीं, सब घर ही पे
but
रहेंगे।
nevertheless that is one
थोड़ा
thing
रेस्ट
that
कर
is
लो।
available
नहीं,
at
एक हफ्ता
bedside.
घर पे रहेंगे।
Fever, especially in a CVA patient, he could have a central cause for fever. Altered white cell count, again, acute cerebrovascular accident can increase the increased white cell count. So what is very important when you want to attribute the lung as a source for the problem is looking at the oxygenation requirement and then you see the pulmonary secretions.
150 180
There are
ठीक है, हो गया आज के डेट में।
secretions.
कल बाप
There
हुआ
is
तो इंजेक्शन हम दिए
increased
थे,
oxidation
इंजेक्शन लिए
requirement.
थे, फिर भी शाम
Then
को
your
शाम को 190
suspicion
हो गया।
towards the pneumonia is much
वास्तव
higher.
ठीक है, हम पे जहाँ
Chest
तक
X-ray to define VAP is
अनुमान है
not
कि 50 दिन में आ जाएगा,
There
लाइन
are
दो
many other
140,
conditions
90, 140,
where
80
the
तक आया
chest
तो
X-ray could be
अभी
abnormal.
कुछ ये है ना,
We cannot
अभी
go by the
मोर
X-ray
सडन
alone
इफेक्ट वाला हो
to make
गया,
a diagnosis
अभी जो
of
उसको
VAP.
मेंटेन करेगा,
X-ray
वो
as a
मेंटेन
tool
का
has got
रिपोर्ट
a
आएगा
more
कम से कम
negative
4-5
predictive value.
4-5
If there are shadows, it could be many
शाम
reasons.
को
in
नमक
which
खाना बंद कर
bacterial
देते हैं, सुबह
pneumonia
का ले
is
लेते हैं।
one of
खाने
the
में
reasons,
नमक डालना
probably the
जरूरी
main
है,
reason.
नहीं तो
So we
सोडियम
have
कम
this
हो जाता है,
score,
सोडियम
or
कम हो गया तो आंखों से दिखना,
CPIS score. Your
चलने में
patient's on a
चक्कर,
ventilator,
वो सब आ
you're
जाएगा।
not sure if it is a
खाते
VAP
रहना
or
है,
not.
बट थोड़ा
And you
खाना।
look
कम
into these
कर
5
दो।
parameters. Look into the tracheal secretions, chest X-ray infiltrates, the
और सब क्या
temperature, the
समाचार
white
है?
cell count,
बाकी कोई
PaO2 by
समाचार नहीं
FaO2
है अंकल, सब
ratio, and
आशीर्वाद
then you go
है।
by the
क्या
microbiology.
क्या
And then
देख
there are
रहे
3
हैं?
वो
scores,
क्लास
0,
क्लास
1,
पढ़ रहे
2.
हैं।
हाँ,
So depending
अभी हम
upon the
पेशेंट
grade,
देखते हैं तो
for all
वो
those
मिस हो
5
जाता है, इसलिए
parameters, you do
रिकॉर्डिंग
some
पर
scoring.
लगाएंगे।
ठीक है, आप क्लास
Scoring is
पढ़िए।
more
अभी
than
कब
6,
तक क्लास पढ़ेंगे सर?
then the chance that someone
ये कर लूँ,
has
इसके बाद
the
PhD
ventilator
करूँगा।
pneumonia is quite
अभी क्या
high.
कर रहे हैं?
ये
Anything less than 6,
फेलोशिप
the
है
chance becomes
हाँ,
less.
लंदन
This
से,
is a kind of a
रॉयल सोसाइटी ऑफ
criteria
पब्लिक
which takes
हेल्थ।
into clinical lab,
इसमें
X-ray,
लोगों
everything
को
we do
पॉलिसी
it.
बनाना,
But
उनके
if you're going
लिए
to have
क्या
a
सूटेबल
positive
है, क्या सूटेबल
microbiology,
नहीं है।
then the value of
जैसे
that
कि अभी
goes
आप
much,
हैं,
much
मान
higher.
लो
You
आपको
give
बीमारी है तो
2
आपको
points for
एडवाइस देना कि
positive
अंकल आप ये मत
microbiology.
करो, ये
So
करो।
you need to keep that also
और
in
आपका
mind.
फ्यूचर बटन, जैसे
Whenever
आपका
you look
इनकम
into the
कितना है,
interpretation
उसके
of the
अकॉर्डिंग आपको
tracheal secretions,
बताना कि आप
X-ray
ये दवा
infiltrates,
खा रहे हैं,
temperature,
ये दवा का इतना
leukocytes,
इफेक्ट आपके
the
फ्यूचर में
oxidation
आएगा। आप
requirements.
एटलीस्ट अप्रोक्सीमेटली
New
इतना
CDC
मनी
guidelines
थोड़ा सेविंग करके
have this
रखिए अपने
component
लिए।
called the ventilator
और
associated
कुछ जो
events,
गवर्नमेंट पॉलिसीज हैं
for which
उनको फॉलो करो।
X-ray is not required.
या इंश्योरेंस
Have this
कुछ ले लो
component called
वो सबके
ventilator associated condition, where more than the X-ray, the focus is on the FiO2 and the peak values. So whenever you have a patient on the ventilator, with the stable oxygen requirements, two calendar days, after that,
ಇದೆಲ್ಲ ಒಂದು ಸ್ವಲ್ಪ
increase in the FiO2,
ಆಮೇಲೆ
increase in the peak value,
ಚಿಲ್ಡ್ ಅಂತ
then you
ಅವತ್ತು
take into consideration
ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಕಾರಣ
new issue happening out of the ventilator.
ಇದು ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಕಾರಣ
There has to be a change in the
ಕುಡಿಯಲ್ಲ ಅಂತ
FiO2.
ತುಂಬಾ ನೀವು ಮಗಲಿಗೆ
Increase requirement.
ಮೇಲೆ
That increase requirement happens after 48 hours of sleep.
ಬಗ್ಗೆ ಕೆಲಸ ಸ್ವಲ್ಪ ಕಮ್ಮಿ
48
ಮಾಡಬೇಕು
hours of
ಇವಾಗ
sleep,
ಅದೇನು ಆಫೀಸಲ್ಲಿ ಕೆಲಸ ಕೊಟ್ಟವಾಗ
oxygenation
ಅಲ್ಲಿ ಹೋಗಿ ಕುತ್ಕೊಂತೀನಿ
at a steady level.
ಮನೆ ನೀವು ಇಂಜೆಕ್ಷನ್ ಮಾತ್ರೆ ಕೊಟ್ಮೇಲೆ ಏನಿರ್ಲಿಲ್ಲ ಆರಾಮಾಗಿ
Okay, my patient is having a ventilator
ಚೆನ್ನಾಗಿ
associated
ನೀರು
condition.
ಕುಡಿಬೇಕು ಸರ್
In
ನೈಟ್
fact,
ತಿನ್ಬೇಕು
criteria for a ventilator associated condition is there. If your patient has fever
ತುಂಬಾ ನೋಯ್ತದೆ
or
3 ಗಂಟೆ ಆದ್ರೆ
hypothermia,
ತಲೆನೋವು
the white cell count is high or the white cell count is low. Plus, we start a new antimicrobial. That is, the clinician thinks an antibiotic has to be started. So the first starting point is your change in FiO2 and peak. If you have fever, the white cell count changes, you start an antibiotic. That is called as an IVAC, or infection-related ventilator-associated events. Going further, that is, you got an IVAC. So you got an event, clinical event, you give an antibiotic. Then you go on to the cultures. So the criteria one is you have positive cultures of
ಸ್ವಲ್ಪ ಮೆಡಿಸಿನ್ಸ್ ಬರ್ಕೊಡ್ತೀನಿ ಅಂತ ತಗೊಳ್ಳಿ
individual aspirate, quantitative culture more than 10 to the
ಇಂಜೆಕ್ಷನ್
power of
ಬೇಕಂತ
5,
ಹಾಕ್ತೀನಿ ಉಪಯೋಗ ಇಲ್ಲ
valve specimen more than 10 to the power of 4,
ಸಾರೇನೆಲ್ಲ ಕೊಡಲ್ಲ
lung tissue more than 10 to the
ನಿಮ್ಗೆ
power of
ಬೇಕಂತ
4,
ಹಾಕ್ತೀನಿ ನನ್ ತೊಂದರೆ ಇಲ್ಲ
protected specimen pressure more than 10 to the power of 3.
ಸುಸ್ತಾಗುತ್ತೆ ಆಮೇಲೆ
ಸರ್ ಸಿಸ್ಟಮ್ ನಮ್ದೇನಿಲ್ಲ
ಇಂಜೆಕ್ಷನ್ ಆಮೇಲೆ
ಅಲ್ಲ ಹೇಳೋದು
ಏನಷ್ಟು
There are
ಖಾರ ಮಸಾಲ ಫ್ರೈಡ್ ಐಟಮ್
ಅದೆಲ್ಲ ಏನು ತಿನ್ನಲ್ಲ
ತಗೊಂಡ್ಬೇಡ
ಸಾಂಬಾರ್ ಹಾಕ್ತಿರ್ತೀವಿ
ರೈಸ್ ಅಷ್ಟು
ವಯಸ್ಸು
to make a diagnosis of either possible
ಅನ್ನನೂ
VAP.
ತಿನ್ನಲ್ಲ ಸರ್ ಮುದ್ದೆ ಮಾತ್ರ ತಿಂತಾರೆ
If
ಅಷ್ಟೇ
quantitative count is on the higher side, then your diagnosis of probable VAP, that is the last diagnosis. Possible VAP is when your quantification does not meet the criteria, but there is positive cultures. So, if there are purulent
ಎಕ್ಸ್ ಎಲ್ಲ
secretions,
ಕೊಡ್ಬೋದಾ ಸರ್
how will I identify a purulent secretion? That is
ಜಾಸ್ತಿ
the quality of
ಟ್ಯಾಬ್ಲೆಟ್ ತಿಂತಾರಲ್ಲ ಕೊಡ್ಬೋದಾ
when your
Drinks
HCl
ಬೇಡ.
cells is less
Drinks
than
ಇಲ್ಲ
ten,
ಸರ್,
white cell
ಆವಾಗಿಂದ ಇಲ್ಲ
white cell count
ಅದು
of
ಬಿಟ್ಟು
specimen,
ನಮ್ಮ
ಎಲ್ಲ ಕೂಡ
ಎಲ್ಲ
ಲಿಮಿಟ್ ದಲ್ಲಿ
ನಮ್ಮ ರಾಮಜಗೌಡನಂತೆ ಅರ್ಧ ಮಾಡ್ಬಿಡೋಣ ಸರ್ ಮಾಡಿದ್ರು
have that
ಇದಾರಲ್ಲ ಅದ್ರ ಮೇಲೆ
plus a positive
ಅವ್ರ
culture,
ಹತ್ರ ನಾನು ಜಾಸ್ತಿ
then
ಈ
you
ಮನೆ
try
ಹತ್ರ ಜಾಸ್ತಿ
eliminating the quantification. The positive
ಬೆಳಿಗ್ಗೆ
culture
ಮಧ್ಯಾಹ್ನ ರಾತ್ರಿ ದಿನ ರಾತ್ರಿ
intertracheal
ಎರಡು
tube,
ಊಟ ಆಮೇಲೆ ಬೆಳಿಗ್ಗೆ
valve,
ರಾತ್ರಿ ಊಟ
lung
ಮುಂಚೆ
tissue, etc. Then also it is called as a criteria, microbiology criteria.
ಚೆನ್ನಾಗಿ ನೀರು ಕೊಡಿ ಟೈಮ್ ಊಟ ಸಾಕು
First level of
ಏನ್ ತೊಂದ್ರೆ
ventilator
ಏನಿಲ್ವಲ್ಲ?
associated condition is change in
ಅದೇ ಸರ್
oxygenation,
ಕೆಲ್ಸಕ್ಕೆ ಹೋಗ್ತೀನಿ ಅವಾಗ
ಕೆಲ್ಸಕ್ಕೆ ಹೋಗಿ ತೊಂದರೆ ಇಲ್ಲ
infection related
ಕೆಲಸ ಹೋಗಿ ತೊಂದರೆ ಇಲ್ಲ
ಹಾ ಸರಿ ಹೇಳಿ ಮೇಡಮ್ ಅದೇ ಈಗ ನೋವು ಬಂದ್ಬಿಡುತ್ತಲ್ಲ ಸರ್ ಅವಾಗ ಭಯ ಬಂದ್ಬಿಡುತ್ತೆ
ಅದು ಕಮ್ಮಿ ಆಗುತ್ತೆ ಅದನ್ನು ಗಾಬರಿ ಮಾಡಬೇಡ
ಅದೇ ನಾವು ಇಲ್ಲೇ
Diagnosis of possible VAP,
ಸರಿ ಸರ್
probable VAP
ಹೇಳಿದ್ಮೇಲೆ
comes
ನಾನು
only with the
ಮಾತಾಡ್ತೀನಿ
microbiological criteria of person. You could either use a quantitative culture, then that is criteria one. If you don't have a quantitative culture, all you need is purulent secretions plus the positive culture. So, to summarize, the VAE or the ventilator associated event definition algorithm is someone on the ventilator more than 2 days, you don't need an X-ray, you have a baseline period of stability or improvement, and then you have a period of worsening oxygenation. Then your diagnosis of ventilator associated condition comes, then you have the general evidence of infection, inflammation, use an antibiotic, then the diagnosis of IVAC comes, use microbiological testing that fulfills, then you make a diagnosis of possible or probable VAP.
ಹಲೋ
So this is how it happens.
ಹಾಯ್
There are some exclusion
hello.
criteria. If your endotracheal cultures go Candida or coagulase negative
Huh?
staphylococci, enterococcus, then you're not making a diagnosis of VAP. Patients on extracorporeal mechanical ventilation, VAP definitely should not be considered in those kind of patients. I'm just asking, is my routine patient on ARDS on prone ventilation? Will I include them in VAP? That's something to discuss about. Because when you're looking at a prone ventilation, most of these patients, when they are prone for more than 48 hours, something like that, it's very difficult to do bundle care. When you're not able to do ventilator bundle care, there's always a risk, especially in patients with prone ventilation. So what are all the analysis reports? You have the VAP rates that you define as the number of VAP by the number of ventilator days, that's the numerator, by denominator into 1000. And you have this another component called device utilization ratio, where the number of ventilator days is the numerator, the number of patient days is the denominator. These are all the metrics that is associated with VAP analysis. So when your patient on a ventilator-associated pneumonia, at 48 to 72 hours, you've done cultures, you're reassessing, the early reassessment. So you made a clinical diagnosis of VAP, started on antibiotics, but almost 50% of those patients, they may not have a pneumonia. So their early reassessment is critical to optimize care. So reassessment happens with good microbiology support. You have culture review, and you look into the culture, check if the isolated pathogen matches the empiric antibiotic coverage. If you thought the patient has pneumonia, but your culture is negative, or when you identify a highly susceptible organism, then you will have to narrow down to a narrow spectrum antibiotic that would target the identified bacteria. That is de-escalation. The culture is negative, then you may have to rethink the diagnosis of a ventilator-associated pneumonia. You would stick on to the pneumonia provided you don't have an alternative explanation why your patient had been reached. At times you can discontinue the antibiotic provided you have alternative explanation to say what happened to the patient in the 48 to 72 hours of the event. Biomarkers, as the previous speaker spoke on, they can be useful and checked. They are not good at starting therapy. Maybe if it is coming down in a patient which had a higher value, then it helps to an extent. Definitely not for making the diagnosis of a VAP. The very first requirement in a hospital or physician is that the sick we should not do the sick any harm. These are words of Florence Nightingale. The last 2-3 slides. This is a new study which I find it very interesting. And of course, I'm not supposed to speak on prevention. The next speaker is going to speak on that. Nevertheless, I thought the study was very interesting. So all patients who were on the ventilator, they did give amikacin in the inhaled form to prevent ventilator-associated pneumonia. And there was another arm where there was no nebulized antibiotic was used. What they found was that a 3-day course of inhaled amikacin was used in their hospital. For all the patients on mechanical ventilation, they did have a good reduction in the IVAC and the VAP rates. This is something to ponder. Of course, there are always side effects of these kind of medicines to use them empirically, but if you can prevent a broad spectrum IV antibiotic to be used much later, giving an inhaled antibiotic with almost minimal systemic absorption is something that we need to think about. As I said earlier, we need to have data on baseline infections, hospital-acquired infections. For that, we need to have accreditation programs. We need to have infection control teams. If there is one component which can reduce all these infection rates, it is having a care bundle approach. This is a hospital in South India. It's from JIPMER. When they tried looking at having a care bundle approach to reduce device-associated infections, they did find the VAP rate can be brought down, the CLABSI rate can be brought down, the QALY rate can be brought down. Because if we talk about bundles, most Indian clinicians think that the data is from the West. Do we have any data from India? Yes, we do have a data. So you have an infection control program, you have a team, and you have systems in place, and then you can have pre-intervention measurements and the post-intervention measurements. You have a real-life examples. By following a care bundle approach, we can definitely reduce the chance that some event happens to our hospitalized patients. We need to engage, we need to educate, of course, execute. Education alone is not enough, and then we need to evaluate our measures. I think these components are much more important in managing our patients. And this is something the administration and like-minded clinicians should pay attention to. This is a useful resource, which is an updated guideline by the NHSM on ventilator-associated pneumonia and non-ventilator-associated pneumonia. Probably the delegates can go through it. It is freely available in the internet. Thank you.
Thank you very much for your comprehensive talk. We're gonna have the question and answers all at the end. And please remain with us, Dr. Nambi. And now I would like to introduce our next speaker, that is Dr. Sachin Gupta, intensivist for Narayana Super Specialty Hospital in Gurugram, if I said it correctly. Your floor is yours, Dr. Gupta.
Thank you. Thank you so much. I just need to share my slides. Right.
Dr. Gupta is the director of the ICU in this hospital.
Thank you. Thank you for the kind introduction. Good evening, everyone, and I would be speaking on the prevention strategies and management about various MDR infections and their risk in the ICU. So I would start with a hypothetical case scenario that Mr. RK, 45-year-old male diabetic with an HbA1c of 9.2, is admitted to ICU with the diagnosis of community-acquired pneumonia leading to ARDS. On the day of admission, the patient is hypoxemic with a PaO2 FiO2 ratio of 150. Patient is intubated on mechanical ventilation with a higher PEEP, and patient is in shock with a SOFA score of 9. If you look at the vitals, the patient, as I said, is hypotensive, so blood pressure of 80/50 on noradrenaline with a heart rate of 120, and patient is also having a temperature of 39 degrees. When you look at the labs, the WBC count is 18,000 with more than 80% of neutrophil count, CRP of 250, procalcitonin of 15, and a higher creatinine 2.1, so which means that community-acquired pneumonia, probably a complicated one with more than one organ dysfunction. Now, when the imaging was done, it showed bilateral infiltrates on chest X-ray, and you started with your initial management in terms of fluid resuscitation and some broad spectrum antibiotics. Let us say piperacillin, tazobactam at 4.5 grams 6th hourly, along with vancomycin and a dose of 15 milligram per kg. Obviously, you will reduce once the creatinine comes to you, and we are doing a lung protective ventilation. So as you progress on the case, by day 4, the patient starts stabilizing with vasopressors being reduced, oxygenation getting slightly improved. However, the patient is now spiking new onset of fever, is showing increased purulent endotracheal secretions. The WBC, which was 18,000, has gradually gone up to 24,000. The cultures are still pending. So do we now say that if this infection is coming on a culture, does Mr. RK develop a multi-drug resistant infection? So this is all I would be talking about. And actually, what is an MDR? When you have to define an MDR, this is an organism which is non-susceptible to more than one agent in more than 3 antibiotic categories. So this is how the MDR is defined, and this is one of the most evolved and resistant organism, and it is not active against any of our most powerful antibiotics. So this is the dreaded infections that we routinely see in intensive care unit. And why intensive care unit? Because this is the single most high risk environment for MDR infections, because you have invasive lines, you have immunocompromised patients, you have patients who have already high antibiotic exposure, who have been routinely in and out of the healthcare system. So it's an ideal ground basically for development of MDR infections. And when you look at the incidence, the CRAB, the carbapenem resistant Acinetobacter, it is almost about of the tune of 85%. And now the carbapenem resistant Klebsiella is on the rise. We still have 72%. And why does this happen? When we particularly talk about the subcontinental scenarios, there are overcrowded facilities, the healthcare worker is to patient ratio is not optimum, there are compromised infection control practices, and obviously there is an increase in the antibiotic exposure to these patients. All these together causes a massive resurgence in the multi-drug resistant organisms. And when you look at this, 1960 we started looking at MRSA, and now we have the Candida auris, one of the most difficult to treat of fungal infections. So in our case, what is the recipe? What I would put it that why our patient should be thought of that yes, this patient can have an MDR infection. Patient is immunocompromised. He is diabetic. Patient is on an organ support mechanical ventilation. Patient is having invasive lines. Patient already has a broad spectrum antibiotic exposure for last 4-5 days. Has been in the ICU, as I said, for more than 72 hours, and there has been a multiple healthcare contact which has happened to our patient. So patient actually has multiple risk factors to develop multi-drug resistant organism. Now, when you look at the burden in India per se, right, and this is a neonatal data that almost 56,000 plus neonatal deaths annually happen, and we contribute or attribute it to drug resistant bacteria. And which are the ones that we are mostly worried about? We name them as an escape pathogens. So we are looking at Enterococcus, Staphylococcus, Carbapenem resistant, Acinetobacter, Pseudomonas, and Enterobacter species. So these are the escape pathogens that we are looking at. Now, our patient had the culture which showed carbapenem resistant Acinetobacter, the CRAB organism. And when you look at the sensitivity only to colistin and cefiderocol, and we are right now cefiderocol is not there in this country at least, but colistin or other polymyxin B group is there. We also need to understand why this resistance happens, and there are various mechanisms with which these organisms develop resistance to our armamentarium of antibiotics. Either there is degradation of the drug by the cellular enzyme, which leads eventually to a drug inactivation, or sometimes there is prevention of the drug uptake due to there is alteration in the membrane permeability. So these organisms, they develop mechanism where the membrane is becomes almost impermeable to the drug, and the drug is not actually entering. Alteration of the drug target, or the efflux mechanism where the drug has actually entered the organism, but because of these efflux pumps, the drug is thrown out of the cell wall, and this is how various resistance mechanisms exist, which makes these organisms drug resistance. So why we should not think about meropenem in our particular case? Because the patient has shown an oxacarbapenem producing agent. Patient has efflux pump as a mechanism of resistance, and there is a biofilm formation of the ET tube. If you have all these scenarios, practically meropenem or any carbapenem group is of no use, and that is the reason it is showing resistance in our culture reports. So, what are these? The independent factors which drive transmission. And when we look at intensive care, we see people coming into the intensive care unit, not only the intensivist, the other admitting consultants, other referring physicians coming. They try to expose these patients, they try to listen to these patients with the help of stethoscope without actually realizing that these small activities are a big hazard for these patients, and this is because of inadequate hand hygiene. If there is a very poor compliance to the hand hygiene, this is the single most critical factor which enables the spread of pathogens from one patient to another. If you're not using your PPE wisely, so incorrect donning and doffing of the personal protective equipment, and obviously if you have contact ventilators and they are direct conduits, so they have to be looked time and again that are they infected or not. So prevention, basically it is not one word, it is a multi-layered approach. So you need to have good hand hygiene, you need to practice your isolation practices as spoken by the previous speaker. The bundles have to be followed religiously. There are bundles for VAP, CRCCID, COTI. So you have to follow these bundles religiously. There has to be a very strong stewardship program in your institute. And then surveillance. It's not that one infection has happened and you stop looking at the patient. No, keep doing surveillance culture, surveillance assessments and decontamination as and when required. Why the role of healthcare is very important? Because the healthcare workers can inadvertently become the vectors for the transmission. So as I said, hand hygiene is very important. You should look at your PP profile, donning, doffing, and very simple staff mobile phones. Actually, you are listening to your phone and then you touch your patients. One of the biggest areas where you can transmit these patients. These small activities are very important, and these are very important specifically if your patient is immunocompromised, because these patients are like sitting ducks for multi-drug resistant infections. So the handrail, the bed rail of the patient, even touching a cannula. Now this is how you're transmitting probably a multi-drug resistant infection which was there on the surface of the bed to the patient's vascular access. Each indwelling device, whether that is a central venous catheter or a urinary catheter or an endotracheal tube, they represent a direct pathway for the resistant organisms to bypass the body's natural defenses. So we should keep looking for the site. For a central venous site, always inspect the site on a daily basis for any erythema, any pus formation. What is the exit and the exit side of the central venous catheter? The similar is for urinary catheter. The basic urinary catheter care has to be done every single day. Hand hygiene is one of the most important steps, and that's the reason WHO has specifically stressed on the 5 movements of hand hygiene. And even if you have a 10% improvement of hand hygiene in your unit, actually it can significantly reduce the transmission rates. And these are the important 5 movements of hand hygiene. That is, before touching the patient, before doing any aseptic procedure, if you have a body fluid exposure, after touching the patient, and end of the day after touching the surroundings. So these are the 5 moments of hand hygiene that one should follow, and this is the most important evidence-based prevention tool for MDR infections. Now, what should we do for our patient? Our patient has been identified as having CRAB, which is multi-drug resistant. So yes, we move this patient to an isolation room, try to cohort the patient, or try to isolate this patient. There should be some dedicated equipment as simple as a stethoscope for this particular patient, and the contact precautions should be followed. What is our goal? We want to spread the outbreak of this MDR, and so there has to be contact precautions. Possibly a negative pressure room could do justice to such patients. Cohorting is very, very important for such patients. Then there are certain decolonization strategies, for example, nasal decolonization. Now you do your surveillance cultures, you take these nasal swabs for the healthcare, for the patients as well, and if you have been identified as carrying Staphylococcus aureus, there has to be some decolonization or decontamination strategy, and this is where mupirocin nasal ointment is applied to the nares, and this reduces the Staphylococcus aureus burden both in the healthcare workers as well as in the patient. There is some evidence of chlorhexidine bathing combination along with this nasal application, and then you do your SDD, which is selective oral decontamination with antimicrobial paste. Now again, there is controversial data on this, that whether SDD does actually reduce the incidence of VAP, or does it reduce the incidence of MDRs. But there is some data that it reduces the burden of potentially respiratory pathogens in ventilated patients. As I said, the controversial chlorhexidine bathing and the SDD, I've just spoken about it. There is no long-term data available for both these strategies that do they help these patients in the longer run. Environmental cleaning is very important. Again, it's a very simple thing, but it helps long run in defending against multi-drug resistant organisms, because every surface in the ICU, whether that is the bed rail, the monitor, the doorknob, they can actually harbor organisms that no antibiotic can kill. And if you look at these high touch priority surfaces, the bed rails, ventilator control panels, the monitor surfaces, infusion pumps, the overbed table surface where we keep our notes and we write, the nurse call button, light switch, the IV set, IV stand, everything is infected, and that's the reason most of the intensive care units where they have good infection control practices will have a policy of doing surface cleaning every 8 hours once the shifts of the GD or the housekeeping staff changes. So probably every 8 to 12 hours you have a policy of getting all the surfaces being cleansed with chlorhexidine. So, if you have sinks and wash basins, always think about Klebsiellas and Pseudomonas. For ceilings, you always are worried about, their reservoirs for Acinetobacter. And these high-touch hardwares, again, are risk factors for multi-drug resistant organisms. So, which is the right disinfectant? So if you have chosen 0.5% sodium hypochlorite, the target is general surfaces and the contact time should be 1 to 5 minutes. When quaternary ammonium compounds are used, the target are environmental surfaces and non-critical items, and the contact time is roughly around 10 minutes. You do your hydrogen peroxide vapor, and this is for an outbreak control or a terminal cleaning, right? And the contact time could be variable. The alcohol based agents are basically skin contact equipments, so as simple as your glucometers, your thermometers, stethoscopes, your pulse oximeters, so they can be cleansed with alcohol based agents, and the contact period is very little, 30 seconds to a minute. And if you have 1% sodium hypochlorite, so you are looking at taking care of infections like C. difficile, blood spills, general surfaces, and the contact time should be around 5 to 10 minutes if you are looking at C. difficile and so on. There are studies about ultraviolet disinfection robots which achieves broad spectrum environmental decontamination, which are particularly for surfaces which can be missed by manual cleaning. Then you can look at hydrogen peroxide vapor because it penetrates every surface into the sealed room, and obviously if you have the facility to put HEPA ventilation in each ICU bed, not only the transplant beds but every ICU bed, then yes, it significantly reduces the environmental MDRO burden. The environmental decontamination, so all high touch surface areas should be disinfected every 8th hourly to 12th hourly, and once your room is empty and if the patient is not there, you can look at actually ultraviolet disinfection. So there should be a terminal cleaning protocol for every patient. Once the patient is discharged from a particular bed, the entire bed surface, the mattress, everything should be cleansed. The monitor, if the bed has a dedicated, monitoring devices, the infusion pumps, they all have to be cleansed before the next patient is wheeled into that bed, and this is a terminal cleaning protocol which should be there. So there is data which says that if you are using an ultraviolet disinfection protocol, it can actually reduce the surface decontamination by multi-drug resistant organisms up to the tune of 99.9%. And similarly, the hydrogen peroxide vapor technology, the advantage is it penetrates the crevices, ventilator circuits, mattress seams, and this is superior for outbreak control. And this is because these surfaces can't be handled by just manual cleaning. Now, when you do all this, everything falls under one big umbrella, and that is stewardship. And this is one of the most important steps in counteracting and dealing with multi-drug resistant organisms in your healthcare setup. So basically, these are not optional programs; these are mandatory programs if you are running a good or a decent, even a decent, infection control program in your unit, because you want to look at antibiotic consumption rates across various wards and ICU units. You want to assure appropriate prescription. You don't want over prescription of a particular antibiotic, and you this is how you will do it by doing prospective audits and feedbacks. And then the end point is we want to reduce unnecessary antibiotic exposure to limit selection of resistance strain. That's the end point by doing all this exercise. So there has to be surveillance, there has to be stewardship, and the end point is reduction of the antibiotic exposure. So choose the right drug in the right dose for the right duration, and that's the basis of all the antimicrobial stewardship program. So you want to do the right test, right patient, right time. So this is diagnostic stewardship. As I said, the antibiotic stewardship would be the right drug, optimized PK/PD dosing, and rapid de-escalation. At the first attempt of de-escalation, we should try to de-escalate, and a very strong infection control practices. So look at PCR techniques and rapid culture to identify pathogens and resistance. So we don't unnecessarily, right? We don't unnecessarily give emulsions from a broad spectrum empirical to a narrow spectrum should be as soon as possible, and this is where these rapid diagnostics help. Yes, the cultures will take their sweet time of 48 hours to 72 hours, and if your rapid diagnostics are helping you out, you can actually narrow down the antibiotic exposure. If the facility of therapeutic drug monitoring is there, do utilize it, because you want to look at your PK/PDs, you want to maximize the efficacy and minimize the side effect. And as I said, de-escalation should always be there in your mind from day one onwards, that I want to de-escalate my antibiotic, right? So there has to be a screening mechanisms for all ICU acquired multi-drug resistant infections like MRSA, CRE, VRE, and from day one onwards. And once you identify such patients, they have to be isolated or cohorted in a similar setup so that they don't spread these infections to the other patients, right? So as I said, you can look at nares and throat for MRSA and rectal swabs or stool swabs for VRE. For CRE, again, rectal swabs has a high carriage rates, and this is the transmission pathway is a high antibiotic exposure. Rapid diagnostics, as I spoke about, multi-top, within 2 hours you will have the answer. Multiplex PCR, 4 hours, and then you have next generation gene sequencing, which again 24 to 48 hours it sequences against 30,000 plus, viruses, bacteria, and other pathogens, and it can tell you what exactly is there. And this rules out the dead part, because this is based on gene sequencing, so only live infective pathogens will only be identified. This is the fallacy of the PCR, which is taken care by the next generation gene sequencing. So the antibiotics that we have as the last resort in our armamentarium, we all know that the polymyxin B group, so both colistin and polymyxin B, ceftazidime, avibactam, tigecycline, fosfomycin, and cefiderocol, and these are our last line. We want to use them very, very judiciously. So the bundles, very important. So if you're looking at a CLAPSI bundle, hand hygiene, maximum barrier precautions. Before inserting, there has to be a good chlorhexidine skin prep should be there. The site selection should be appropriate, preferably the subclavians and the IJVs, and that the patient can avoid on its own. The VAP bundle should be for head air with chlorhexidine. There has to be a sedation holiday, because you want to look at every opportunity that you can take this patient off the ventilator. The cuff pressure should be checked so that you can try to prevent the micro aspirations as much as possible, and the circuit management. So once you follow these bundles, the risk is reduced by 30 to 70%. Again, the pharmacokinetic optimization is very important, because you don't want to underdose the patient, you don't want to overdose these patients. So you should consider that there will be some change in the volume of distribution, specifically in septic patients. The volume of distribution increases, so you need to change the dosing of your patients. Either the patients are hypoalbuminic or patients are on some sort of renal replacement therapy. So all these will have augmented renal clearances, and one should be very, very clear about what dosing of antibiotics will be administered if your patient has an ARC. So that this is where your therapeutic drug monitoring, extended infusions, loading dosages, and how do you dose escalate in various conditions. So it's a team effort, both intensivists, infectious disease specialists, microbiologists, pharmacists, nurses. It's a team effort once you're looking at fighting the MDR. And as I said, as early as possible, de-escalate both in terms of antibiotic from a broad spectrum to a narrow spectrum, and secondly, the duration of the antibiotic has to be as short as possible. So hand hygiene is one of the most important thing. The staff has to be educated. You should have a very strong antibiotic stewardship program. Environmental cleaning plays a very important role. Wherever necessary, please wear appropriate PPE, and active surveillance should always be a part of the culture identification. So in our case, by 14th day, the patient started improving. The fever resolved, cultures became negative, oxygenation improved, and the therapy was de-escalated and stopped appropriately. So this was all about the case. Now I will touch few slides about what are the recent IDSA guidelines 2024 about MDR treatment options. So when you look at be. Now, the principal organisms are like oxygen, Klebsiella, ammonia, TS Bacillus, and when you look matrix as in, if you complicate cystitis, nitrofurantoid are the ones that we routinely see in intensive care units, right? The preferred would be trimethoprim, sulfamethoxazole, or some fluoroquinolones, but what we generally look at is carbapenem group because these are the ones which are generally resistant to the above antibiotics, and we look at carbapenems and sometimes aminoglycosides. If patients were on piperacillin tazobactam, and this was a study which looked at the Merino trial where they looked at if the patients were on piperacillin tazobactam, and they found that there is a high resistance mechanism and there is a high risk of failure of treatment if these patients are being given tazobactam because it provides insufficient inhibition against high ESBL inoculum and multiple beta-lactamase. So they said do not use piperacillin tazobactam for invasive ESBL infections, even if the test in vitro shows that the patient is sensitive to this. Now, if your patients have carbapenem resistant enterobacterials, so look at is the CRE positive? If yes, then is it non-carbapenemase producer or a carbapenemase producer? If non-carbapenemase producers, ertapenem or meropenem or imipenem could be there. But if the patient is producer, then what is the mechanism? If this is KPC, then you look at combinations of a BL-PDL in terms of meropenem, Bacterium or Ceftazidime avibactam or imipenem cilastatin relibactam. If the patient has a NDM, WIMP, IMP producing Ceftazidime avibactam plus estonam because avibactam protects estonam from co-produced serine enzymes, or if you have cefiderocol, then well and good. And if you fall into a OXA 48 like producing organism, that is the class D of the Amber classification, then you look at ceftazidime avibactam, right? So you need to identify the resistance mechanisms to guide your antibiotic therapy. Similarly, if you have a difficult to treat pseudomonas, again, when you say difficult to treat, it means the patient exhibits non-susceptibility to piperacillin, tazobactam, ceftazidime, cefepime, meropenem, imipenem, cilastatin combination, ciprofloxacin, and levofloxacin. So if you have these resistance in your culture report, this means that this is difficult to treat Pseudomonas aeruginosa, and for these, you can look at ceftolozane, tazobactam, ceftazidime avibactam, imipenem, cilastatin, relibactam combination, or cefiderocol. These are the only four antibiotics which may actually help you in treating these organism, and this is the triage matrix, whether you are looking at uncomplicated cystitis or majorly for pyelonephritis or complicated UTI. The crab carbapenemase resistant Acinetobacter, again, it is one of the most difficult organisms to treat because unlike in other species where sulbactam is just a beta-lactam inhibitor, in Acinetobacter abomini, it is an intrinsic bactericidal antibiotic that specifically binds to the PBP1A, 1B and PBP3 protein. And so here the combination therapy is very, very important, and combination therapy with at least two agents unless you see any clinical improvement. So either you have a sulbactam and durlobactam combination, and then along with carbapenem, or you give high dose ampicillin sulbactam, and secondly you can give minocycline, much better than polymyxin B or cefiderocol. So minocycline actually scores here much higher. So again, a combination if you don't have the durlobactam available in your setup. So this is the master synthesis when you look at all the antibiotics and which antibiotic against which specific multi-drug resistant organisms can be helpful. So in our case, the patient was fine. The patient got discharged from ICU on 19th day and hospital discharge on 26th day. So the patient survived not because of any miracle antibiotic, but because prevention, stewardship, rapid diagnostics, environmental control, and multidisciplinary teamwork were eventually brought together. And this is what antibiotic stewardship is all about, and this is how you fight and prevent the multi-drug resistant organisms. So MDR pathogens are not the norm, they are not the exception, because this is there, we can't ignore them, but we also have to understand that if somebody has MDR, there is an increased mortality, the ICU stay or the hospital stay will increase, and eventually all will land up into an increased cost to the patient. You need to follow strict infection control protocols. So hand hygiene ranks 1 in that. There has to be a very stringent environmental cleaning process, and contact precautions should be there. Please have an antibiotic stewardship committee in your organization, because that will audit, that will look at how the clinicians are prescribing antibiotics, and can we educate and can we do something about it so that we reduce the antibiotic exposure in a healthcare setup. As early as possible, if you can detect your MDR, so there has to be rapid microbiological tests which are available. And as I said, it's a team effort. There has to be a multidisciplinary approach about it. Thank you so much.
Thank you, Dr. Gupta, for the interesting and comprehensive talk. And we're gonna move now to the questions. I will start, if Dr. Chawla agrees, from the questions in the chat. Is that okay, Dr. Chawla?
Yeah, sure.
So, the first question was about the nebulized antibiotics for the prevention of VAP, amikacin nebulized, that it was mentioned in the first talk. What type of neb device it was used?
It was an ultrasonic nebulizer, and looking at giving antibiotics as a nebulization, in general we should resort to the use of ultrasonic nebulizers, because that is what delivers the finer particles of these antibiotics lower down the respiratory tract. The purpose of highlighting that study is to think out of box, and that was not the norm, but it is something that we need to think about it. So let's not keep that as the to-do thing to prevent VAP. But we'll have to use
I agree.
Right? Yeah.
I agree with you. We need to have the correct device in order this not to stain the trachea and go deeper in the lungs. And of course, in terms of VAP prevention guidelines, we need to not just a study. They asked also if amikacin nebulized is available in India.
Yes, it is available. There are at least a couple of companies that I know which produce amikacin. I'm not sure. Tobramycin is definitely available. I'm not sure about amikacin. Perhaps Dr. Rajesh Chawla is a pulmonologist. He may be knowing. Tobramycin is available as a nebulization. I'm not sure about amikacin. Tobramycin is available as a nebulized form. There are standard couple of companies with recognized brands, and amikacin I'm not sure.
Dr. Chawla, do you know if they have neb amikacin? Because it's the question, if they have neb amikacin in India.
Neb? Amikacin.
Amikacin.
No, they don't have. They don't have. But I think we hardly use. I am not quite pro of using the antibiotic by inhalation. Even the ITSA guidelines, in most of them, they are against the use of inhaled antibiotics.
Yeah,
we have been using colistin for a long time, and rarely we use even now when patient is not responding. But I am somehow hardly, because I feel that it's a disease which is everywhere, and inhaled will not reach everywhere in the wherever the infection is. So I hardly use, and the evidence also now doesn't support, particularly in Acidobacter. They absolutely say that you should not use it.
I might kindly disagree, not for neb themselves, but we have published a study from Greece for Acinetobacter that had better outcomes, but of course combined with iricolistin. And I agree with you, the guidelines and from ESCMID and the guidelines they do not suggest, did not recommend a standard the nebulized antibiotics. That's true. I would say that we might, my opinion, we might tailor when we have MDR as Acinetobacter, and I would say XDR, not MDR, XDR or PDR, we could do as adjuvant or we can do it for ventilator-associated tracheobronchitis to have high doses without having systematic. In VAP, in tracheobronchitis, just nebulized, but in VAP, of course, always with IV and selected cases. So although I say disagree, I agree with you, but in tailored cases, I would give it in the correct dosing. Now for the net colistin, they say higher doses up to 5 millions every 8 hours. So the guidelines do not recommend generally to use the NEBs. If they are used for selected cases, like let's say as for carba pneumonia, along with IV antibiotics, and with the correct devices to reach the lungs. There is another question about, we have a patient with tracheostomy and remains with tracheostomy and develops pneumonia, how you would characterize if you not ventilated anymore, if you could characterize, and I assume more than 48 hours after end of mechanical ventilation, the patient developed pneumonia. Would you call it ventilator-associated pneumonia or would you call it HAP?
If someone is not on a ventilator and then develops a pneumonia later, so someone has been off the ventilator, so I don't think we can take that as a ventilator-associated pneumonia. It could be taken up as a hospital-acquired pneumonia, or the new NHSN terminology, there is something called as NVHAP, that is non-ventilator hospital-acquired pneumonia. So, because someone is not on the ventilator, then you are not invoking the diagnosis of VAP. It will be called as the hospital-acquired pneumonia. I have a different viewpoint. This terminology of hospital-acquired itself, it gives a kind of a wrong connotation. I always see it this way. The patient is sick enough not to go out of the hospital. So I don't think we can blame the hospital for that. So we'll have to see it in a different way too. But I do agree that we have to have some kind of terminologies. That is something for societies to discuss and then decide. So,
yes.
Because I do run infection control program in our hospital. So my only question is, can I do something to prevent it? And if I have done it and something happens, then I think I cannot put it as hospital acquired. I see the patient is sick enough now to get better. So that it's a problem is because of hospitalization. I don't think it's hospital acquired.
Maybe they mean that it's acquired in the hospital without the connotation. I understand what you mean. You mean not to say that the hospital has caused it. Although we might, we need, I agree, prevention measure, infection prevention and control to improve the conditions. And I think the hospital can become better. Okay, I would like to mention something. I think it's not the most important thing if it is called HAP, it is called VAP, it is called, and agree with you, it's HAP, and nosocomial, let's say nosocomial pneumonia. I think the important thing is what is the pathogen and how to treat in that specific case. I take the opportunity to mention something. There is in general, when we read articles, we need to understand what they mean using the terminology. All their nosocomial pneumonia, because nosocomio in Greek means hospital. All their nosocomial. Those in patients that they are not intubated, those that they might or not deteriorate and end up in the ICU intubated, and they might develop in the ICU in non-intubated patient or in patient with a tube in, and we say the ventilator-associated pneumonia. In the IDSA guidelines, they call HAP only when the onset is before the tube, and they call VAP when the onset is 48 hours after the intubation. This is with the ATS IDSA guidelines. In the European guidelines, in ESCMID guidelines, with HAP is they define everything, and 80% is VAP. And they call non-ventilated HAP, and then when the onset is before the tube, but the patient deteriorates and ends up in the ICU intubated, they call it ventilated HAP. So my suggestion, and I have mentioned that in a presentation that I have done in the past, to see what definition they use when they have they write the articles. And I would like to mention HAP onset before that in non-intubated patients that deteriorate and they end up in the ICU, they are a subcategory with the worst outcomes, the highest mortality. And this was when I had my PhD like almost 20 years ago, and also in the ENIRI study that was recent, the ventilated HAP, again, the HAP that onset in non-ventilated, non-intubated, non-ventilated patients that ended up in the ICU was the worst mortality. It is because the diagnosis is delayed, because we cannot take an invasive sample. It is the type of patient that they develop it. We need to research further. Can I continue with some more studies through our two speakers? In the 2016 IDSA ATS guideline, they redefined the definition of VAP, and they said if there is clinical suspicion, it is not prerequisite the new or deteriorated infiltrate, because many times in the ICU, the chest X-ray, the chest X-ray that is done in the bedside are not very specific. How does this affect our diagnosis in the ICU? What do we do to mitigate, and what are the pitfalls to both of you?
Sachin.
When we say the X-rays are probably not of good quality, or let's say not of good exposure, when you really want to look at and diagnose VAP per se, what we do in our unit is we just don't blindly rely on the chest radiograph, because there are limitations in ICU patients per se. You don't have a standing X-ray, you don't have a view. So we'll utilize other modalities, like we look at lung ultrasound. If the feasibility to do a scan, as in a CT chest, is there, we utilize that. But based purely on X-ray to diagnose VAP is actually a little tricky situation when it comes to intensive care patients. It's not so easy. If you really have to use only one criteria, that I start seeing new infiltrates on an X-ray to diagnose this as VAP in a ventilated patient post 48 hours, I would still rely on other factors before confirming that the chest radiograph is showing me VAP only.
Yeah, that's why I think that because they say it's clinical mostly.
Yes.
To give the option to the clinician, if they have strong suspicion, it's not clear what is happening. Now we have a CT much easier if we need to see, and also the use of lung ultrasound is becoming more and more and more common, and that's why the CPIS, although it's not that it's not a score, now they say. Diagnosed without even they click the boxes of CPIS, and that's important. The pitfalls is it's to the intensivists to balance not to overdiagnose, and on the other hand, not to underdiagnose and risk the patients that if the patient has VAP and deteriorates, and we do not start early the correct antibiotics, we know that the outcomes worsen, morbidity and mortality. So it is then for the intensivist, infectious disease specialist, the team, to find the correct balance. And I would like
Can
to...
I come in? You see,
course.
one of the very important thing which I have seen is, one of the common indication, I do a CT scan in an ICU is, suppose X-ray is not looking that bad. Patient is very sick, is deteriorated. I know there is something. That's the commonest indication. Everybody's saying patient has aspirated. X-ray is hardly showing a little bit. You get a CT and you find a big shed. That's the common thing which I think one really gets help, because when you are taking a sample from bronchoscopy, it really helps you to go to that area and take the sample. That also, if particularly patient. So CT has a role, but then if this patient can be shifted to the CT room, that's another thing. We don't have a portable, so patient has to be can be shifted, because if he's on a very high vasopressors, then he can't be shifted. But he can be shifted. And I have found not one, many a times, much more anatomical localization of the lesion, and helps also to diagnose where we were not sure whether it is a VAP or something else causing new onset fever in the ICU.
Absolutely, totally agree with you, Dr. Chawla. I will go to the next question. And we say that HAP and VAP might carry different profiles. What is your opinion about the early, late VAP? We said, and it was mentioned by Dr. Nambi, early VAP, roughly the threshold less than 5 days from intubation, late more than 5 days, but at the same time, very nicely, it was highlighted that more than 5 days in the hospital is high risk for MDR. So what we're gonna take? How many days in the hospital, or how many days with the tubing? For you, Mr. Dr. Nambi.
What I spoke was theory. To be
1 day 25 type ಹೋಗ್ತಾ ಇದೆ ಈ ತರ ಬಾಟಲ್ ಜಾಸ್ತಿ ಕೊಡಿ 25 ಹೋಗ್ತಾ ಇದೆ ಅಂದ್ರೆ ಅದು ಶುಗರ್ ಕಾರಣ
organisms as a cause for
ಶುಗರ್ ಮಾತ್ರ ಹೇಳ್ತಾರೆ ಅಂತ ಇದೆಯಾ
if it is post influenza, generally it's the typical community acquired pathogens, whereas the patient who is hospitalized, the data that we have
normal ಇದೆಯಾ ಸ್ವಲ್ಪ ಮಾತ್ರ ಬರ್ಕೊಡ್ತೀನಿ ಅಂತ ತಗೊಳ್ಳಿ ಒಂದು ಶುಗರ್ ಟೆಸ್ಟ್ ಮಾಡಿ ಖಾಲಿ ಹೊಟ್ಟೆಗೆ ಬೆಳಿಗ್ಗೆ ಖಾರ ಬೇಡ ಅದಕ್ಕೆ ಔಷಧಿ ಬರ್ಕೊಡ್ತೇನೆ ಅನಾಯಿಂಟ್ಮೆಂಟ್ ಬರ್ಕೊಡ್ತೀನಿ ಔಷಧಿ ಬರ್ಕೊಡ್ತೀನಿ ಏನು ಹೆಸರು ವಯಸ್ಸಷ್ಟು
so I don't find that distinction anymore in real life practice. But the postgraduates who are attending to this, so for them to know the distinction, I came up with that idea. So there is that extent, the distinction is getting blurred.
We have so much resistance. So I think this early and late was about 15-20 years ago. Now no longer, because even early is a MDR or XDR. So as he said, it is very difficult to say it is early or late. Our choices almost remain the same, but there are all patients who's come from the community. Let's say a patient has come from the community and within 24 hours he gets it, or less than 48 hours he gets pneumonia. Then there is an odd chance that he may, if there is no risk factor, that he may be carrying community-acquired pneumonia. But I think most of the patients, we don't think of the community-acquired pathogens causing the early or late.
I think we should take, regardless how long the patient, let's say even if it is in the first 5 days of intubation, if the patient for several days, they say cut-offs more than 5 days, but this is continuous. It's not cut-off, but if it's more than 5 days, and to take into account all the risk factors that we were mentioning, how often the patient have contact with the hospital, if he was a colonizer in the past, if he was admitted in the hospital, all the risk factors. We need to tailor our approach, to tailor with the risk factors of the patients, and also the baseline, as it was very nicely mentioned, what it is in our ICU. This nice picture with the airplane and people, Indian people, that we show and say, not what is happening in UK, in France, in US, but what is the surveillance data of our unit, our flora, our resistance. We need to have this information, and we need to have it regularly updated, and also take into consideration previous, let's say for some hospitals ICU do surveillance data. If we have data from surveillance from the same patient, that's useful as well. And how much time do you have for this module? Dr. Chawla?
Yeah, what did you say?
How much time do you have for the module?
No, you can carry on.
Or can carry on. So I would like to say about ventilator-associated events. Should ICUs in India implement VAP tracking? For what the VAP tracking would be useful? Would it be for everyday practice or for other issues? To any of you.
Dr. Nambi, she's asking whether it is just for surveillance or for everyday practice.
तुम्हारा मर्जी है वो सेठ जी को दिखाएगा उनको मालूम चल जाएगा क्या हुआ है
I think there are two ways. So even in our ICU,
3 साल से खाना कम खा रहा है, लोग बोला नहीं, कई बोल रहे इधर चला
infection control professionals,
वो ब्रश
they
उससे
have
नहीं
this as
कि
surveillance map.
वो
So
ज्यादा
there are two
तीखा
kinds
ठंडा
of things. One is for your
ज्यादा
preparation
डिपेंड
programs,
करता है बाहर का खाना वो सब यूज करें
so that you get prepared. But as a clinician, if you
कोई
are a
चीज पसंद
clinician,
आता ना
they are trying to
दबा के
take care of
खाता
the
है
patient.
वो नहीं करनी चाहिए
I don't think in that
नीचे
situation,
देखो नीचे
surveillance
ये
definition
बाकी का सब
applies
एरिया
much.
देखो और गले का
That
एरिया
is for to discuss
वो
with
पूरा लाल
in a
होके
courtroom,
इन्फेक्शन हो
in a
गया
relaxed manner, comparing data with
ये
your
थोड़ा
own
दवा लिख के
hospital,
देता हूँ वो ले लो गर्म पानी में नमक डाल के गार्गल करना है कारा मसाला
bedside,
फ्राइड आइटम
you go by the
बाहर की
clinical
चीजें ठंडी
definition,
चीजें
clinical
ज्यादा
sense.
तीखी चीजें नहीं
Dr.
खानी
Nambi,
Yeah.
I totally agree with you. That was I brought it up. The wide definition are useful for surveillance, comparison, and if you have automated system that make it easy, you can use that. But as you said, for everyday practice, it is not for everyday practice.
Yeah, I would like to add here. So as rightly said, these are very good for creating your KPIs, key performance indicators for JCIs and other. If you look at the definition, surveillance definition, VAP, right? You will actually underscore the VAP incidence in your ICU. You will hardly define anybody having VAP if you go primarily by the surveillance definition, which is like fourth day of the ventilator, which is again very fourth day after the VAC event. So it is underscoring it. Clinical definition and clinical scenario VAP incidence versus the surveillance incidence of VAP. They will never match.
आपने देखा होगा छोटे बच्चों को हम बहुत सारी
They don't match.
चीजें करवाते हैं सब्जी वगैरह में वो लोग फिर क्या पसंद करते हैं
And if you don't have automated system, it's
फिर वही
difficult
मानते
to
हैं
have them.
क्योंकि हम उनको उसकी आदत
I
डाल
don't
देते
say
हैं
that they are not useful, but they
तो
are
वही
for,
फिर फ्यूचर में हमको
they
ट्रबल
are
करेंगे
different things, and I would say they complement each other, like complementary, not one.
अच्छा चीज बोला है पूरा दिन कुछ भी करो 1 घंटा शरीर के लिए छोड़ो इससे ज्यादा लिमिट खाओ दिन में 2 बार खाओ तो भी चलेगा अच्छा चीज
different reasons, and I think it's very important to improve also our clinical diagnosis. And now, as we say, we use the CT more often, we use also the ultrasound. We have
ज्यादा खाओगे तो वही एनर्जी है कम खाओगे वही
rapid test.
अच्छा
I
चीज
would like to go to the PKPD that it was mentioned, and I will. You have already, Dr. Gupta, you've mentioned that about the Blink 3 study and the meta-analysis that included data from Blink 3 study. So I think that the reply is there, but I would like you to re-emphasize how would you go for beta-lactams, for meropenem, piptas? Would you go with extended or continuous infusions? Or what do you do in practice?
So we follow the extended infusion protocol only. So for example, if I have to give a carbapenem, meropenem, we generally go for a 3-hour infusion. After the loading dose, when we have to give it, we look at a 3-hour infusion specifically. So we look at meropenem, a 3-hour infusion. If you are giving imipenem, cilastatin combination, right? You look at a 2-hour. If you're giving ertapenem again, our combination. But yes, a continued infusion, but not as in you make an entire daily dose and continue it for 24 hours, because that's not there. The dose is actually stable. Once you dilute an antibiotic, it is stable not more than 8 hours at room temperature, or let's say the ICU temperature. So you don't give the entire, let's say if I have to give 6 grams in a day, I won't dilute that 6 grams and continue it for 24 hours. It will be 2 grams, 2 grams, 2 grams, and each dose will continue for 3 hours.
Yeah, it is prolonged infusion. It can be extended or continuous. For us that here we do continuous, they just change the bags. So the SRMA has shown prolonged infusion, with prolonged infusion that include the way you do it, the extended one, the way that we used to do it in Greece as well, and the continuous infusion as we do it here. Both they are under prolonged infusion, and the SRMA showed something impressive with a simple procedure. One life is saved, extra life is saved every 25 treated with prolonged infusion, as you do it and as we do it as well. What do you do when you have augmented renal? First, what dosing do you use for ICU patients? Do you use 2 grams every 8 or 1 gram every 8?
No, so 2 grams every 8 hourly a specific indication. So if I'm looking at, let's say, meningitis, right, or if I'm treating an immunosuppressed patient, then we are looking at a 2 gram 8 hourly. Otherwise, we generally use 1 gram 8 hourly as the maintenance dose.
For VAP, the loading dose will still remain.
The loading dose is 2 grams, but you divide whether I want to continue 2 grams 8 hourly or I want to continue 1 gram 8 hourly. It depends on the subset that I am treating here.
Somebody asked me a question. You have given 2 grams. When are you going to start maintenance? Immediately or after 8 hours or 6 hours?
For us in the continuous infusion, we go to 24 to 48 hours, regardless the renal function, because you need to load them well in the first 24 or 48 hours, at least the 24 hours. And if you have suspicion for a higher MIC is a bit higher, or for VAP, for VAP I would go for if I have a normal renal function or augmented renal clearance, I would continue several days with personal
opinion. We don't do also because the stability problem of meropenem.
No, I don't.
It doesn't remain stable. So that's why we get 3 hours.
Sorry, I didn't say. Okay, I didn't say I would go. You can go either continuous or extending. I say that I would, if we have augmented renal clearance or suspicion of higher MICs, still sensitive to meropenem, I would continue in VAP. I would continue 2 grams every 8 for more days. In terms of continuous infusion, I clarify. We say continuous, but it doesn't mean that you use the whole lot in a one bag for 24 hours. They change the bag because of stability. This is clear. We have very clear protocols on that. Another thing that I mentioned before about PKPD, I said that for 24 or 48 hours, regardless if the patient had AKI, at least for 24 hours, I would go for the full dose. To have during the day the 6 grams.
Okay.
When you have augmented renal clearance, that it was mentioned, suspicion, let's say hyperdynamic circulation, especially trauma patients, younger, the first week of the ICU admission, and you have suspicion of augmented renal clearance. Let's say you have eGFR more than 90 and you have suspicion that it's augmented renal clearance and it is quite higher, more than 120, more than 130. Do you do clearance with urine collection or it's not easy?
No, it's not easy. It's not at all easy. So whenever we have a suspicion that probably this patient must be having an ARC as in an augmented renal clearance, we actually overdose, we increase the dose based on the clinical scenario, rather doing these measurements and then following the formula and then putting, so we categorize the patients accordingly, and if we feel yes, this patient has an hyperdynamic circulation, right, whether this is sepsis, trauma, pancreatitis, massive fluid, shapes and all that, we multiply and we say we'll overdose these patients, so let's say 1.3 times the normal value. This is how we say that whatever the dose we were thinking about to give to this patient, let us increase this by 1.3 times and give that dose based on the renal clearance.
Is it often that in your in India to have TDM for beta lactams?
We don't have TDM for beta lactams.
Thank you. So to sum up, prolonged infusion that include continuous and extended, both under prolonged have shown that they have better outcomes. You can do it with 3-4 hours. You can do it continuously with loading dose always. But when we say continuously, because of stability, it is not for 24 hours continuous, but different 2 grams in a bag. Then when it finishes, a new bag and a new bag. So to take into consideration the stability, of course. So we are pro prolonged infusion because now we have the data there, the evidence. I will move on and I will say about duration. What is your opinion about short duration? And when we say short duration, what do we mean about short duration? Because there's in the past they were saying short duration the 7 days, and now they try to do the ultra short. What is your opinion? And when we finish, I will take my opinion as well, if I might.
When we say short duration, ultra short duration, 7 days duration, I would say it has a regional. The decision will be based on your flora and fauna, right? In my ICU, if I am giving carbapenem or let's say ceftazidime bactam for an MDR, I have never given it for 3 days or 5 days. I think that's not the, yes, it looks very good on papers. Let us talk practical. No, 3 days, 5 days is frankly speaking not possible, at least in the Indian scenario that we are talking about. So the minimum duration that we have ever given is 7 days duration, right? That's the minimum. I would for this ultra short duration, the papers which have come up, actually it becomes very, very clinically difficult to justify that 3 days, 5 days and step down to something else or change to something else when the patient is improving. You want to continue that winning combination if your patient is improving till the time the patient becomes relatively more stabler to step down onto a different antibiotic. So for my take is 3 days to 5 days is a very, very short duration. I don't see that very feasible in the Indian subcontinent, but I would like to hear Dr. Nambi and Dr. Chawla's opinion as well.
2-3 days dalli adu kammi agutte but ಪೂರ್ತಿ ವಾಸಿ
Sir, you are muted.
ಬಿಸಿ ನೀರು ಕೊಡಲೇಬೇಕು.
Very high incidence India. As he said, less than 7 days I have never given. And for non-fermenters, anyway, you have to give a longer 10 to 14 days, like Acidobacter and Pseudomonas.
ಒಂದು ಟ್ಯಾಬ್ಲೆಟ್ ಕೊಡ್ತೀನಿ ಈಗ ಬಾಯಿಗೆ ಹಿಂಗೆ ಚಿಕ್ಕಬೇಕು ಈ ಮೈಕೈ ನೋವು ಜ್ವರ ಎಲ್ಲ ಬೇಗ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ರೆಸ್ಟ್ ಮಾಡಬೇಕು.
Non-fermenters was to give around 10 to 15
ಏನು ಹೆಸರು?
Now we are stopping at around 7 to 8 days with respect to ventilator-assisted pneumonia. But let me put it across, it's not a blanket rule. So just because the guideline says you can stop it early, doesn't mean that all your patients, it should be stopped at day 5, day 7, day 8. Ultimately, we look into the patient. Stewardship is good, but it's not at the cost of the patient sitting in front of you. You need to keep that also in mind. We need to balance outcome of the patient in front of us with respect to the broader objective of stewardship. Having said that, gone are the days where we were giving 10 to 14 days for our Acinetobacters and Pseudomonas VAPs. most often now we stop around 7 to 8 days. We are very comfortable to stop around 7 to 8 days. This is where we stand as a group in terms of infectious disease and critical care physicians. India is a big country and everywhere they have their own regional preferences and variations. We are comfortable around 8 days. 8 days is that day we are with that ballpark figure of 8 days. General, most often, 90% of our patients with VAPs, we stop antibiotics by day 8.
May I say my opinion on that? My take. I think those that they stop 3 days and everything was okay. Maybe it was not VAP at all from the very beginning. I have it might have been VAP or something else. Usually it is 7-8 days now. Also for like I said, the bacterial pseudomonas, etc. But always we need to tailor to our patients. And I agree, it's in front of us the patient, and we need to tailor based on patient characteristics. The guidelines, they say that if we need to go more than 7 days, then we can take into consideration, apart from the clinical picture, also the PCT. It depends if they are NDR, XDR, how we have started, if we have started with appropriate treatment or not, and we can go for more days as well. I agree with you. The ultra short, it's not for the type of VAP that you see, or for having this new Cochrane meta-analysis of duration of VAP. Very soon we're gonna have the results. But I can tell that it is not found that the ultra short. And I can tell when we say short, let's think the short compared to the old, the 7-8 days, because this is the, how can I say, it is now this is confusion in definition. When we say short, we mean the very short. No, when we say when we have the comparison and in the Cochrane, it will be clear that when we say short, we mean the 7-8 days compared to the older 10-14 days. But again, it is tailoring, adjusting, and some patients may need much longer, as Dr. Chawla said, that you said that we may give 10 days if the patient do not improving or not resolving, or try to find other causes, or try to see if we have another pathogen that is not sensitive, or we have a complication. I would like to move on and say, although I think that the reply is in the guidelines, would you give a selective digestive contamination in India as VAP prevention, SDD? It is in the guidelines, but
we don't give it.
With such a high incidence of resistance, so this is not done in India. I don't think any center in India is practicing this.
Absolutely, and it is clearly, I just, it's a very nice question. I just brought it up to emphasize that India is a high MDR prevalence, and in the guidelines it should say can be considered in low prevalence scenarios, but no in high prevalence scenarios. I would like to ask about antibiotic de-escalation, but we have, I think, covered. The question is how we can de-escalate, to define the concept, the barriers in the Indian ICUs, and how do we implement it effectively. I think we have partially covered that, but if you would like to mention something more, when we have the result of the cultures. if we can do targeted. It was mentioned by Dr. Gupta.
So
but sometimes it's difficult. Because
sometimes it is difficult. So either if we have a culture and we can narrow down the antibiotic very well, right? Or if you don't have the culture and the culture is negative, let's say to start with, but you started on a higher end antibiotic. So either you have the timeline, or if the patient starts improving, then you downscale your antibiotic. But then it becomes a more of a clinical decision.
Yes, clinical decision, as you say it, because even with negative, if we have high suspicion and we don't know what it is, it's difficult because the yield of cultures is not that high. Then I would like to ask, you have a problem with CRAB, carbamazepine-resistant Acinetobacter. What do you do? What do you use commonly as optimal strategy for CRAB in the Indian ICUs?
So we use high dose sulbactam along with minocycline is what we generally use when we are looking at Acinetobacter.
When you have yes, thank you. When you have
we don't have Dalobactam, so that's the reason we go to high dose.
We sometimes use polymyxins also with minocycline. Sulbactam also, there are a lot of ID specialists are saying there is resistance in India. And although they say that even if you find resistance, you should still use it. But then it becomes 3 antibiotics. So you have to decide in patient to patient which. What's your practice, Dr. Nambi? I'll ask him as well.
I try to keep it simple. I use drugs that has been reported as sensitive. So as simple as that. Most often the polymyxins, even though their penetration in the lung may not be that great, but I tend to use polymyxins for Acinetobacter plus a high dose tigecycline or minocycline. If minocycline is susceptible, comfortable using polymyxin plus minocycline. Minocycline is not susceptible, then if tigecycline is susceptible, use tigecycline. If the tigecycline minocycline is not working based on susceptibilities, then use sulbactam. The sulbactam, the ITSA guidelines recommends very strongly. Personally, I feel the evidence base for sulbactam, for Acinetobacter, is not that strong. And of course, the sulbactam durulabactam is a different molecule altogether, but we don't have that. I think polymyxins plus tigecycline, minocycline, plus or minus sulbactam is my practice. So I think that is what we do. I think Dr. Chawla, we are 20 minutes past the time, and then I leave it to you because you are the organizing person. Yeah.
Can we wind up now, ma'am?
Yes. Can we have a last question, if possible?
Sure.
What do you do for MRSA? Do you prefer vancomycin, linezolid? Do you think it's the same?
We have teicoplanin as well. In India, we use a lot of teicoplanin, and if it is for lung, linezolid is a good penetration and a good drug. So I prefer linezolid for lung many times, but generally most of the people, because better renal profile, they prefer teicoplanin. Although it is not practiced in the West that often, the teicoplanin.
For VAP, I agree with you. Because of the penetration, I prefer linezolid. Yeah. And if the patient is critically ill, teicoplanin may take some time to do steady state. So yeah, if we have suspicion of MRSA, so we run out of time, correct? Or we can continue. I would like to thank Dr. Chawla, Rajesh, and Dr. Aakanksha Chawla. It has been a pleasure being here in this module, in this forum. I wish and I hope we have more collaboration in the future. Very, very interesting. And also thank you, Dr. Gupta and Dr. Nambi, for very, very interesting presentation and discussion.
Thank you.
Let's see, the chat, we have something. Sorry, I don't want. Okay, nothing more. Perfect, perfect. It's been a pleasure.
Yeah. So thank you, Dr. Despoina, for giving us time, and it was really pleasure. And with the interest and deep thought about the subject, you moderated this session. Dr. Nambi and Dr. Sachin for taking wonderful lectures, and Dr. Sachin particularly the very high-tech slides. And it was a pleasure to watch. And Dr. Aakanksha, as usual, given a wonderful recap of the last module. So next we have on 16th, that is on the gram-positive infections. We have 2 talks on that day. We make at the same time with the recap of this module, and then we'll discuss the gram-positive. See you next time, 16th June at the same time. Thank you very much. Have a good night.
Good night. Good night, everyone. Thank you.
Good night. Bye-bye.
Bye. Thank you.
Thank you so much.
Thank you. I will send you. We have a. I don't remember if I sent you.